rather than medular anterior venous fistula?
Yes. PL fistula.
Fantastic. Another question is if you consider also doing an angiography for follow-up or MRI, just to be sure that it's not a recanalization.
Sure. We perform a DCA 1 month after the treatment and was completely occluded. And now we are waiting because this case probably they reached the 6 months after the treatment in January.
Fantastic. Okay, guys. I don't know if Pedro, you have any comment, any additional comment?
No, it's okay for me.
So again, I want to thank you because we are ready on time. It's 4 minutes left, so we can move on. So thank you very much for your participation and for your effort. This is the first session of Nightmares. So again, as with your cases, we'll learn a lot from you guys. Thank you very much. Just to remind that I will let you know some other questions for the audience maybe later on, or you may reply to the website. So let's keep in touch, okay? So I think we finished. Thank you.
Thank you very much.
Hey, Mario.
Thank you.
Thank you a lot and keep pushing.
Okay, we finished the Spanish session and we are going to move to the German session, which is also amazing, moderated by Professor Jens Filler. So let's go ahead and learn along from them. Thank you very much.
Excellent.
Bye-bye.
Hello and good morning, guten Tag from Germany, and buenos dias to Mario to Spain. And it's our great pleasure to be here as the second team and represent Germany with Franziska Dorn, Maxim Bester, and Paul Stracke. And the cases that we are presenting have one common theme, is that we have lost something. Let's just jump into it and then have a great discussion afterwards. Let's start with the first case from Maxime.
So hello to all of you. My name is Maxim Bester. I'm from Germany, actually from the north of Germany. I live and work in Hamburg, and I'm very happy to participate in this, well, I think we might say monumental event. So 24 hours of complications, of nightmares. This is incredible, and I'm very curious what will happen in those 24 hours. Us three from Germany, that is Franziska Dorn, Paul Stracke, and me, we decided that we'll share complications, our personal nightmares with you where we lost something. And this is why I'll share my complication case where I lost embolic material, in this case fill, during a treatment of a complex carotid cavernous fistula. So those are my conflicts of interest. I'll only make a brief clinical introduction of the patient. Actually, it was a 57-year-old female who presented to an outpatient clinic with a rapid progressive visual loss. They actually already did an MRI, so she was scheduled at our department for diagnostic angiography, where CC fistula was already suspected. So first, I'd like to show you those images we acquired during the angiography. So this is injection in the left external carotid. This is the injection in the internal carotid with late phase, and I believe I don't have to explain the features to you. We have the indirect carotid cavernous fistula, and the treatment plan at that point was to have a transvenous coil occlusion of the cavernous sinus. So actually, this was a little bit more difficult than we thought. The ipsilateral jugular vein was occluded, so we thought, actually, you see, we had a very large intercavernous sinus. We thought the way would be very easy, but like it's usually in venous navigation, was far more complicated than we thought. And actually, although this looks straightforward, there was no passing from the right to the left cavernous sinus to occlude the fistulous compartment. So we rescheduled the patient, and at that point, our axis of choice to do a direct puncture of the ophthalmic vein. Actually, just to conclude, you could have achieved this access via the facial and angular vein, but the direct puncture was our axis of choice at that time, and actually straightforward and pretty easy. So those were images taken from the second intervention via direct puncture. So those are images from the arterial access. And here you see in a lateral image, pretty easy, the catheterization via the ophthalmic vein of the cavernous sinus with the microcatheter. And actually, this was the last unsubtracted image you see. Coiling was straightforward. You could believe this access is very easy. And although we did not achieve very dense coil packaging, we had complete occlusion at the time. So actually, we thought, why continue? We have occlusion. We thought this would be fine over time. Of course, no nightmare when this case wouldn't continue. So the patient came back after only 3 months with a recurrence of the red shunt eye. And as you see in the right time-resolved MR angiography, there was a recurrence of the CC fistula. So we rescheduled the patient for diagnostic angiography, and those were the images from the common carotid injection on the left side. So what you see is that the inferior lateral trunk is now the main feeder. And on the contrary, we still have cortical drainage on the contralateral side. So of course, besides the clinical presentation with the shunt eye, we certainly have an indication for treatment. So of course, before treatment, we did a plan. before we rescheduled the patient. And because we thought that the ILT is the main or almost the only feeder for the indirect fistula, we will put a covered stent, in this case an anograft stent. So this is a stent, a laser cut stent that is covered with horse pericardium. For those who don't know this, it's a balloon mounted stent. We will place the stent over the ILT to close the feeder, and if there would be still some little feeders from the external carotid artery, we would try to occlude them with PVA particles to start thrombosis. So the patient was scheduled for intervention, and we did our working projection, and actually we looked a little bit longer at the working projection. So although we had a plan, we looked at the trunk of the inferior lateral trunk, and we thought, well, this looks quite large. It's remodeled because of the fistula. Maybe we could intubate this trunk with a microcatheter. Our first choice was the Hathaway Duo embolization catheter, and add some fill embolization directly in the fistula to have a better result. So we tried that because of this tortuous anatomy of the inferior lateral trunk. This was actually impossible with the Hathaway Duo microcatheter, but finally we were able to navigate a sonic fuse CAT inside the inferior lateral trunk, and this is an injection from the sonic fuse CAT where you see that we are actually very near the fistula. So of course, what you see here, it's maybe a little bit confusing images because we have so many coils, but of course we didn't manage to navigate the sonic fuse CAT directly in the middle of the coil packet. We just entered the ILT a little bit, and you see the detachment zone of the sonic fuse CAT is far inside the ICA. So we thought, well, we didn't intubate the target vessel, the ILT, far enough maybe with the sonic fuse CAT. So we thought we'll put a Scepter, so a double lumen balloon catheter in the ICA for safety. And on the right image, you see the inflated balloon directly over the ostium of the ILT. And we thought this would give us enough safety to not have reflux inside the Barent vessel, inside the cavernous ICA. So this is the first roadmap. You see it's already a little bit into the embolization. We already have a little bit fill inside. But one thing I'll maybe jump back that I'll see now, we didn't realize this during the intervention, that those images are a little bit confusing. So of course, the delineation of the parent vessels, so the ICA from the cavernous sinus, is difficult in those means, but it still gets more difficult when we have coils inside. So we started embolization. So this was the first step. We have a little bit more fill inside the cavernous sinus in the middle of the coils. And the next step, you see something happen. We have fill on the tip of the balloon microcatheter, of the double lumen balloon. And at that point, we were sure we have aberrant embolization of fill in the parent vessel in the ICA. So, of course, we first stop the embolization. In this unsubtracted image, you see fill on the tip of the balloon, and we deflated the balloon, did a very sensitive run, and what you see is fill directly next to the ophthalmic artery in the cavernous part of the ICA adherent to the vessel. So a horrible thing, certainly something we at that point didn't thought would happen, and we thought about solutions to this problem. And actually at that point, we thought three solutions would be possible. So we had the Scepter inside, and we had the Scepter like laying over the aberrant fill. And we thought maybe we could stand the fill to the vessel wall. The second idea was to now put the covered stand over the ILT and those fragments of fill. For this, actually, the Scepter and the sonic had to be removed because our guiding catheter, of course, was not large enough to accommodate the Scepter, the sonic, and the anagraft delivery system. The last possibility we thought of was to leave everything in place and try to aspirate and remove the fill immediately. But actually, I can't explain exactly how this decision was made, but we decided that we fulfill our first plan and put the allograft in place, and with this movement close the fistula and stent the fill to the vessel wall. So of course, Step-down Sonic had to be removed, and during removement we saw, probably just because of movement of those two microcatheters, change of situation. So now we don't have any fill anymore beside the ophthalmic artery, but we do have fill. Now you see it better in the unsubtracted image in the MCA bifurcation. So of course, what happened, we somehow manipulated the fill embolus in the carotid cavernous compartment and had embolization far distal. So the same that usually happens with a cardiac embolus. So what to do now? We knew, of course, we had to remove the fill somehow, and we tried different ways. So first of all, we tried aspiration only, and this is a very short video. So here you see the tip of the aspiration catheter, what is Sophia Plus in this case, and just above this you see the fill. And while I start the video, you see we were able to capture the fill during the first couple of centimeters of retraction of the Sophia during aspiration. But we usually, in this case, we lost fill just here, but we usually weren't able to remove those larger parts completely. So of course, probably a guiding catheter would be helpful in this case, because we could do something like flow arrest or even flow reversal. But of course, like we first planned the intervention without a guiding catheter, balloon guiding catheter, and actually we didn't think of changing our normal guiding catheter towards a balloon. So we tried, in the end, we could separate those larger fragments a little bit. So here you see aspiration of a small fill particle, and actually when those particles were small enough, smaller than the lumen of the Sophia, as in this case, we could ingest them completely, but still in the end we had larger parts still sticking in the bifurcation. So we tried different kinds of combined technique with stent retriever and aspiration, like in this case, but still you see fill is very sticky, adherent to the vessel wall, and still even in combined procedure we had difficulty because we lost the fill fragments all the time and had to repeat the procedure. So after more than 2 hours of philectomy, this was the final result. So the patient had quite good collaterals. We elevated the blood pressure and gave some glycoprotein inhibitors as a bolus. And we thought, well, so this result is as good as we could achieve. Unfortunately, so of course, the patient was under general anesthesia all the time. This was the result in the CT 3 hours later. So probably because of this manipulation of the fill adherent to the vessel wall and pulling the vessels, we had this severe SAH with intracerebral hemorrhage parts. The patient had to undergo a hemicraniectomy afterwards, unfortunately. So this is it with my personal nightmare. So unfortunately, the story of this patient is not over, but our time slot is not long enough. And now I'm very curious about the discussion with Jens and the other participants. Thank you very much.
Thank you very much, Maxime. So I think this definitely qualifies for a nightmare. This is exactly what you don't want to dream about at night. I like your term philectomy. I hope it doesn't become a regular term because it happens rarely, fortunately.
Me neither. This wasn't a nice case. Nothing to be repeated here or anywhere else, I believe. Yes.
So my first question to you is, so if you compare your experience with the Sophia Plus and stent retriever, what do you think, what was the best effect from your gut feeling or your experience?
I believe so. The case was a couple of years ago, and fortunately, this was the only case where we had to do philectomy. So thankfully, our experience is very, very, very low. But I believe combined technique was the best to achieve, like how grip onto the fill fragments and retrieve them. And what I believe we should have done, take the time to change for a balloon guiding catheter, because we, as you saw in this video, so I think I didn't make them large enough, but we could grab the fill, but we lost the fill on the way, no matter if we used aspiration only or combined technique. And Of course, I don't know, but I had the feeling that having a balloon catheter in place and doing aspiration on the balloon catheter to maybe even achieve flow reversal would have helped a lot, no matter what technique we would have applied on the fill fragments themselves.
Any comments from the other wise people?
I have a question for you, Maxime.
Yes.
The case is awesome. So if you have the case today, first, I have two questions indeed. Do you think that Onyx, for example, or Squid have the same retrieval than the fill? So do you think there is any difference in terms of retrieval? Because my perception is that a Squid or Onyx may be retrievable easily compared with the fill.
So I have to say I don't have any experience with Squid, and I would share your experience or your idea with Onyx that Onyx is not as sticky to vessel wall as fill, but actually I never, thank God, I never had to do Onyx retrieval. So so I believe that the worst mistake was not to take fill instead of Onyx, but the worst mistake we did in this case is that we actually had a good plan and we did a lot of pre-planning, what we think is crucial in complex cases, and then we just changed our plan for actually no good reason into something completely worse. And then we all know that we didn't have enough safety distance for embolization. We had just a little bit of the sonic embolization catheter inside the fistula. And we all know, so at that point, we just didn't realize that the balloon just gives tell safety and you still can get aberrant embolization. Nevertheless, you have a balloon. But I share your opinion, probably it would have been easier if we had this complication with Onyx, maybe even with Squid, but still, I think there were other steps we should have done to avoid this complication at all, yes.
And listen, do you feel that maybe, if you have the case right now, do you feel any difference between SOFIA versus other bigger intermediate catheters like Embovac or Vecta with more surface aspiration may help in this situation? Or you still had the preference of SOFIA because of the navigation? What is your opinion?
So we still use, for stroke cases, we still use SOFIA Plus. It's the aspiration catheter of our choice. I believe it's the to go for stiffness and lumen is great, better than the Vecta in my opinion. I believe in this case, a larger lumen aspiration catheter would have been crucial because you saw that we could ingest the smaller particles, just the larger particles that we couldn't ingest just tear down with the vacuum we lost. So I believe something maybe even like the Millipede, very large lumen aspiration catheters would have helped here. Yes, but nevertheless, if we had used large lumen aspiration catheters, we wouldn't have been able to use a balloon guiding catheter. So it's a trade-off. Actually, I don't know, and I don't want to run into the same situation again to try it out. Actually.
Quick additional question. What do you think is the actual mechanism of the hemorrhage? Did you get the feeling that you really lacerated the arterial wall or how does it work?
Yes, in the end, you've seen this and you've seen it in one video that the film was so sticky that you just moved the whole vessel tree, and we moved it far a lot when we tried to detach the fill, and I believed we got laceration and I don't think it's a bleeding in the large infarction because of vessel occlusion in those 2 hours.
Yeah. Franziska, any wisdom from your side?
No, I'm just happy that it never happened to me so far.
Yes,
but I mean, it's the fear that's always there when you use Onyx or anything else. I know from one case in our department where we lost some Onyx in a young AVM patient. It was possible to get it out with a stent retriever, but I also think you have to be quite quick to get it out. So it would have been there a possibility to just leave it where it was, because in the beginning I could not see the screen very large. So, but in the beginning it didn't really look too bad, did it? I mean,
we we didn't have complete occlusion, but we have the feeling that Phil from all embolics that we have is the most thrombogenic. So we were very fearful to have a complete thrombosis, and we didn't want to wait actually to see this thrombosis. So you might be right. Maybe it's different with Onyx. I don't know how Squid is, but I believe Phil is very thrombogenic. So it's of course good when you do venous embolization, but in this case, it's horrible.
Yeah, so Minsil is making a very interesting comment, and they said that when we see material in ICA, we put the retrieval distally before moving the balloon in order to prevent distal emboli. I think it's very important. It's a good tip just to put something there like a, like a filter, in order to prevent this type of migrations.
Yes.
Yeah.
Yes. Yeah. That's right.
Perfect. I think that's a very good conclusion for this case, and let's just all hope that it never happens to us. Thank you very much again, Maxime, because it was a real nightmare also to share, I suppose, to relive this. It's
yes, as we say in Germany, Hosen runter.
Hosen runter, exactly. Okay, so next presentation from Franziska, and she has also lost something. I think that's was the common theme here.
Thank you very much for the invitation. When I went through my cases for this event, I actually found that there are two different types of nightmares in the angio suite. One is the sudden shock moment, and the other one is a rather slow torture, which can last for hours or weeks. So I found one example for each of those scenarios. The first case is quite quick, is my sudden shock moment. I lost my web. So this is a case of a 37-year-old male patient whose brother had an aneurysm as they age. So this is why he had an MRI, which showed two aneurysms. One is an ICA aneurysm and the other one is an A1 aneurysm. He is a heavy smoker. He's very anxious, and he asked us for treatment, but if possible, not with a stent, because he didn't want to be on antiplatelet medication. This is a case I did together with Thomas Liebig in Munich. So this is the 3D, small but broad-based A1 aneurysm. And this is the actually angio. And this was my working projection. So we planned to put a web in there. This is the microwire in the aneurysm, the microcatheter. It was a VIA-17. And then I deployed the web. It's an SL 3x2. I thought it looked good. This is with contrast. And well, I detached it, and then came the shock moment. The microcatheter obviously jumped into the A2 segment, and so did the already detached web device. And why was this so? Well, there was this quite uncomfortable angle into the A1 segment with a lot of tension on the microcatheter, which I noticed, but I thought it would be actually fine. Then the first thing was I tried to get it out with a stent retriever, but it didn't work. It just turned the web a little bit, and after a few minutes, we had some thrombus on the device. And now the proximal marker pointed towards the vessel wall, which was bad, of course. Then we tried to snare the proximal marker, but we couldn't catch it. And well, then we decided that we had to fix it against the wall. So we used a stent, an Elvis Junior. But after 5 minutes, we saw narrowing of the A2 segment. So we implanted a flow diverter pipeline in addition to get more radial force. Looked fine in the beginning, but after 1 minute, we had, again, some narrowing of the vessel. And after 5 minutes, almost complete occlusion of the A2 segment. So we put another pipeline in there and gently dilated it with an Eclipse balloon. And now it looked fine. We put him on Agrastat, and after 20 minutes, it was still open, no narrowing of the A2 segment. And we left it like this. We didn't treat the aneurysm in this session. The patient woke up and he was fine. And now he was on antiplatelet, so he agreed to have the other aneurysm, or the aneurysm treated with a flow diverter. So this is what we did 2 days later. So we had a control after 48 hours. A2 is still open, looks fine. And then we treated the aneurysm with a pipeline. And this is the final run. And this is the control after 6 months. So still everything is open and the aneurysm is gone. Well, there is not a lot of reports on lost web devices. I actually found only one case report by Sebastian Fischer from Bochum, who had to retrieve this web from the MCA, but I think he was quite lucky because the proximal marker pointed towards him, so he was able to catch it with an alligator and retrieve it. And there's an animal study that describes retrieval of lost web devices with a snare, so this obviously can work. And I think this is quite interesting also by direct aspiration with the Sophia, for instance. So, but I hope I won't need this knowledge anymore. Then comes my second case. This is the slow torture. I found a thread. It's a case of a 61-year-old female patient with an incidental supraophthalmic ICA aneurysm. I don't remember why she had an MRI in the first place. So this is the first angio we had in 2015. Quite large aneurysm, quite tortuous vessels. This is the 3D. And the first treatment was done by a colleague of mine, and he was quite clever to perform an occlusion test before he started the treatment. She had good cross-flow. She didn't develop any symptoms, so we had this information. And then he treated the aneurysm by means of coiling and flow diverter implantation. There are the distal markers of the thread and there are the proximal markers of the thread, and I think this is a quite good result. And the patient was fine. She came to an MRI control after 6 months. She didn't want to have an angio, and we saw complete occlusion of the aneurysm. And then she came back another 9 months. So this was almost 1.5 years after the first treatment, And we were quite surprised. She came because she had visual impairment of her right eyes and visual field deficits to the left side, which was this developed quite rapidly. And we were really surprised when we saw her MRI with recanalization of the aneurysm and massive increase in size. So we did an angio, and of course we saw compactation of the coils, we saw massive inflow, and this is where I found the thread, not in the vessel itself, but at the level of the aneurysm entrance. Here the distal markers of the dislocated thread flow diverter. Now all the flow was directed into the aneurysm sac, and by this pumping it kind of up. And now comes the slow torture. It's just super difficult to get into the MCA through this flow diverter, dislocated flow diverter, because the microcatheter, microwire were also directed into the aneurysm sac. So I put some more coils in there. And finally, it was possible to get the microwire into the MCA. But then I didn't know if I was in or outside of the flared ends of the thread. And so I used an Eclipse balloon and inflated it a little bit. And since the markers did not move, I thought I was in the thread and not in the flared ends. I exchanged a microcatheter, and then I deployed a very long Leo stent. This is 4.5 by 50 millimeters. And of course, there was some inflow left, but at this point, I just left it like this to stabilize it a little bit. And some months later, I deployed a second flow diverter. This was a Derivo in this case, but very difficult to orientate with all this material and these tortuous vessels, but I think it looked fine. So this is almost the final control, but then after 20 minutes, there came another shock moment. The ICA was occluded, and I put her on Acrostat. get some recanalization, and then I actually saw the problem. Here, the markers of the Derivo, they are not open, so it didn't open proximally. And so I went in there with an eclipse balloon, and after dilatation, the markers were at the wall, so it was open now. And this is the final control. Everything is open. And control after 6 months showed complete occlusion of the aneurysm, but the patient did not recover. She's basically blind on her right side. So, well, thank you very much. I think we will discuss the cases after all of our presentation in this session. Thanks again.
Thank you very much, Franziska. Absolutely. So I totally share your view on these two types of complications. The slow torture type, I think, is particularly painful because the other thing is more, straightforward in a way. Let's just start with the first one. So I think the key message is if you lose the web, you should make sure that the longitudinal axis is oriented, is in parallel with the vessel where you want to retrieve.
I mean, it's obvious now, and actually I noticed this, there was a lot of tension, but it's the moment where you decide, well, it can be fine or it can go wrong. So I did the wrong decision. In retrospect, this is not a web case, I would say. I would not treat it, but he didn't want to have a stent, so probably this is what I learned from this.
Yeah.
Not even in some, you could not have even put an intermediate catheter in the A1 segment, and I think it would not have helped.
Yeah. So, any other comments from the wise people in the panel?
Yeah, Franziska, thank you for sharing those two cases. Extremely interesting. I have a question to the first case. Do you think it's only the tension problem that the web dislocated, or would you say now that it was undersized in some form, additionally to the tension?
Maybe would have been better if it was a little bit larger, but when you measure it, it didn't. It was smaller than the nominal size. So I think even the largest one wouldn't have held the tension or the release of the tension. Yeah. Okay. I think this was the problem. Yeah.
And then I believe you were very brave to put so many stents in the A2 and that it worked. What do you think the narrowing, because it looked very cut off at the proximal, was it at the proximal stent? Do you think it was thrombus or spasm or both?
I think that if you have the web in your hands, it has some force, right? I mean, it takes some force to compress it. I mean, this was really. I tried to get it out, but then you move the marker towards the vessel wall, and then actually someone stopped me from doing this because before I teared off the vessel wall. So I'm quite thankful for this. But so this was the only solution we could think about. But I would think, I mean, you could actually try this like in a model. Why doesn't the radial force from the Elvis Junior is not enough for compressing the web? This is quite interesting, I would say. Yeah. I mean, in the end, we were lucky. This could have been worse. There was at least no hemorrhage. Yeah.
So in the end, your experience is you need at least one Elvis Junior and two pipeline to compress the web to the vessel wall. It's quite a lot of metal. Yes.
Yeah. Now I do like in PICOM aneurysm with the web or anything like this, where you actually have a similar angle. I'm really scared. So.
Yeah. Any other comments to the first case, Paul? What would you have done?
Not a web.
Not a web. Okay. Yeah, certainly. That's typically the first problem for the nightmare is the first step. Yes.
So I thought the comment and the discussion with Maxim was very important, that a braided stent usually has not enough radial force to compress such a device, and I would always prefer than a laser cut stent like old Enterprise or Cado or something like that. And usually braided devices don't help in that situation. No? That's my idea.
Mm.
Yeah, very interesting. And the second pipeline case, not the pipeline case, but thread case. And do you think, of course, in retrospect, that the distal part was too short, so the landing zone?
Yeah. But I think this is quite interesting because we are constantly told that the flow diverters get intimatized after some weeks or months, and this was, I think, 1.5 years after implantation. So it was still possible that it moved just by itself. Of course, the implantation was not ideal, but he just tried to not cross the A1 segment. She had really tortuous vasculature. So, of course, this was not ideal, and but I think it's interesting. Why does it just jump into the aneurysm after more than 1 year? So
I wondered if the aneurysm maybe has grown distally. It was too quick for me. Do you think it was still the same?
It was already occluded on MRI. It was already occluded. It looked fine on MRI. She didn't want to have an angio. This is bad luck, I think, in this case, because then we may have seen it, but it was already completely occluded. So I don't know. But this is a good idea. But I don't think so because the MRI didn't show any inflow. At 6 months already. Yeah.
We have also some experience in this direction, but it was always, we considered it always, let's say, our mistake that it happened. But maybe there are also some natural occurrences that
probably. Yeah.
This.
I think this the implantation or the placement was not ideal in this case. So it was too long proximally to the aneurysm, and she had really very tortuous vessels, so it was very difficult to see. So
and anything you could have done different. Sorry.
We have some
Mario.
question for the audience. Sure. Jens, do you want?
Yes, please.
So we have a first question for the first case. It's a question about the shape of the microcatheter. If you think that making some shape in the micro would be more stable for the body. What do you think about it?
Probably yes, yeah. So, but I haven't thought about this because it was quite easy to usually do this to get a better catheterization or make catheterization easier. But catheterization actually was quite easy to get in there.
You know, I don't know, because at the end we change the shape for some webbing. At the end, because of the stiffness of the system, they straighten again. So I'm not pretty sure if you find a real stability. What do you think, guys?
We now have the pre-shaped vias before we did steam shaping, and my very little experience with the pre-shaped microcatheters. They're a little bit stiffer and they keep like in sidewall aneurysms or in such strong angulars. They give a little bit more stability only when you use the smallest web. So I think it was 4x2, Francisco?
3x2.
3x2. So extremely
one,
small. In my opinion, it might help a little bit, but this is a very small experience, and I don't know. So usually, when you're able to move a intermediate catheter as near as possible, as Francisca said, it was impossible in this case. This gives you some stability in high angular cases. So.
Yes. We have another question: is if you consider pardon vessel occlusion, regarding that you have a nice contralateral flow theoretically.
In the first case?
Yeah, I assume that is second case.
Yes, yeah. Actually, when I mean, in the end, this was just an extra shock. When the ICA was completely occluded, we were thinking about leaving it like that, but then it took like 6 hours or something to get into the MCA, and then I didn't want to ruin this or to waste this what I've reached. Yes, it would have been one option that we actually discussed. Yeah.
Actually, I was very surprised as you opened the artery, just placing the pipeline. I think it's a very important tip for the people, because at the end, I think the cobalt chromium are the ones for this type of opening, right?
Yes. Yeah.
Okay, we don't have more questions here for the audience. I don't know if you want to comment something else, Jens.
Just one final question. So the Eclipse balloon, were you happy with the performance for the dilatation?
Yes, in flow diverters, yes.
Okay.
I think it worked fine in this. Yeah, I mean, there was so much material. It may have not worked in this case, especially with Derivo, but it worked fine. This is what I often do after placement of FlowDivert is I use the Eclipse just to give it a little bit more wall
massage
and to open it a little bit and massage it into the wall. Yes. Yeah.
Okay, got it. Okay, so thank you very much, Franziska. Excellent, very, very instructive cases. I think we all learned a lot again. And now the final German, Paul Stracke, and his, I think it's about losing with thrombectomy materials.
Good morning, everybody. This is Paul Stracke from Münster in Germany, and I have a case about problems in stroke. My title is What Can Get Lost in Stroke? It's a little bit older case, but it's a very common problem that can happen. So we have a typical case of a stroke patient with hemiparesis and aphasia, NIHSS score above 10, not so old patient with 69 years, and the onset of symptoms was less than 3 hours ago. In the CT angio, we saw a typical tandem lesion with an M1 occlusion and an occlusion or high-grade stenosis of the internal carotid artery. So these were the angiographic images after we decided to go for thrombectomy, and we see a pseudo-occlusion of the carotid artery, which you can see on the left image here with a calcified plaque with a subtotal occlusion and a very slow flow of contrast to the intracranial vessels. So we cannot even see the occlusion of the MCA in this image. So the old question is what to treat first. Should we first treat the lesion in the internal carotid artery, or should we treat it at all? Or should we go for the MCA occlusion? In this case, because of the calcified clot, we decided to treat first the lesion of the internal carotid artery. The question is here only doing a PTA or doing a PTA in stent. And to my experience and according to the literature, it seems to be better to put a stent inside. It's not such an issue with bleeding problems. So I decided to go for a PTA and a wall stent in this case. I did this very fast without doing any run, just doing on the roadmap and go for the intracranial thrombectomy. I used a solitaire device, stent retriever based technique with a balloon guide with proximal aspiration. And in this working projection, I did the thrombectomy as usual. And when I tried to retrieve the microcatheter and the solitaire retriever with a blocked balloon guiding catheter, I felt a very strange resistance at the end of the retrieval maneuver. So what was going on here? I thought, what's happening? Do I have a very stiff clot? Do I have a second stenosis, a proximal stenosis or vasospasm? Or is it just the solitaire device got stuck in the stent? And then I took a look further down with a run from the internal carotid artery, and I saw here the solitaire in the distal end of the wall stent. We all know that the wall stent is usually easy to pass, but the ends are not without problems for such devices. And then I forced a little bit more. You see also the clot inside the solitaire device. And I thought, okay, let's take it out a little bit with more force, a little bit orthopedic maneuver. And then I could manage to tear it off, and the solitaire got stuck there. The pusher came out, and I made a second run in the intracranial vessels, and you see the MCA is still occluded. So what are our options now? What to do? Should we just end the procedure and say this is a fail of thrombectomy? Should we do intraarterial lysis, which might work and lyse the clot in the MCA and then the proximal artery? Or should we go further for a second stent or for a snare maneuver? in this situation, I decided to put a second wall stand to fix the solitaire retriever against the wall and not to try to get it out with a snare, because I thought this could be a very traumatic maneuver. And I put a second wall stand, but in this hectic, I saw this result. The stand was very nice and the carotid artery was straight, very nice. But you see that distally, the device had moved to the petrous segment of the carotid artery. And again, we have still an occlusion of the MCA. So this is not finished, or this is not easy to go further. Again, the same questions. Should we do some lysis? Should we put a third stent in this situation to the petrous segment, which then has to be another stent like a Neuroform or whatever, self-expanding stent or balloon expanding stent, or should we snare it? And now I had enough experience with my stents, and I decided to go for a snare. I took a normal 4mm snare to take the device out, and it's pretty easy to grab such a broken retriever, and it was pretty easy to get the device back into the guiding catheter and to tear it completely out. And after that, we could do as usual and finish the thrombectomy with another retriever, this time having the tip of the guiding catheter all the time in our sight, not to make the same mistake again. So what I learned from this case, which was an early case some years ago, it's easier to go for the MCA first and to do the thrombectomy. You cannot get this problem when there's no stent before the end of the procedure. And on the other hand, I have seen a lot of cases with clot forming up around the guiding catheter when you put it into a freshly implanted stent. If stenting before is required because you might have a very calcified stenosis of the internal carotid artery, keep the guiding catheter always inside. I was sure that I put it through the catheter, but during navigating into the intracranial vessels, there might have been some kickback, and this caused the problem that I showed. The good news is when retrievers tear off the pusher, they can be taken out with a common snare, mostly a 4mm snare. Over the years, I did it 2 or 3 times and it always worked. Thank you very much for your attention.
Yes. Thank you very much. Very, very interesting case, and something that probably happens quite a lot of times around the world. And yeah, you said that it happened a while ago. It wouldn't happen to you anymore now?
I hope so, yes. So if you are in hectic and you are not, yeah, you have to keep your guiding catheter inside on one plane. It's easy. Usually I do it on the lateral plane. And it didn't happen for, I think, a handful of years, but I would never exclude. And I think this is not a very fancy case, but this happens from time to time. And on my own, I did it 3 times. And I know a lot of cases where it happened also. And I think the good news is you can take it out, and to put it, to fix it with a stent, I think it's more efforts to compress such a device to the vessel wall and put a huge stent inside. And I didn't even succeed with that. So that's, but usually, of course, our experience is growing, and usually this should not happen again, yes. But a high amount of thrombectomy and 3 at the night, it can happen, yes.
Yeah. Absolutely, that's I totally agree. I think Franziska, you published a paper exactly on the subject, which to distal first or proximal first.
I had exactly the same case. This is why it made us finally change the way we did it. So I always start distally, and if I have to, I don't think you have to put a stent in first, because you can just do some PTA, and now with Sophia or anything, you can just go through. This is normally possible. So I learned a lot from my similar case. Actually, I couldn't get it out, so I just fixed it with another wall stand. This taught me something. And there are many discussions about it. I think there are more disadvantages than advantages of going distal first and then proximal. This is at least from our small series, which we published some years ago. You're faster and so on.
Yes, I think this discussion is sometimes very clinical. What is better for the patient is a difference when you stent first or when you treat the MCA occlusion first. We also had a big series of those cases. We compared it and we did not find any difference. But I think from the technical point of view, not to run in such a complication, or what I always see or very often see when we have to stent before or when we do it sometimes, and you work with a guiding catheter intracranial, you sometimes have complete clot around the guiding catheter in the freshly implanted stent. And I think from this point, if it's possible, take the MCA first. If not, make a PTA. I think you are completely right. And if not, if you want to place a stent in the beginning, beware of these problems which can occur.
Paul, I do have a question, if I may. When you say you have experience with 3 cases where the stent retriever disconnected, were those all solitaire cases or like through different stent retrievers? Can this happen with every device?
So I think it can. Today it's very rare. No, I think in the early years, the solitaire was originally designed as a detachable stent. And
so this case was with a solitaire AB, if I understand you.
Yes, this was the AB stent, but we had it later also with a second generation solitaire. I think even with a solitaire Platinum was the name, I think. And where I heard it a few times from other colleagues, and when we experienced on our own, was with the old Catch device, Catch Mini device, which sometimes got teared off. And I think most of it is a little bit historical, because modern devices are better fixed to the pusher, and on the other hand, we learned a lot more how many force to apply to get it out. And if the resistance is too high, you have to think about it and perhaps get up with the intermediate catheter, take it out, or similar things. But over the years, I heard a broad spectrum of lost devices. But from my experience, it was more Catch Mini in the beginning. It was a lot of solitaires, but perhaps only due to the high amount which was used in Germany over the time. I didn't try to tear off a modern device in the last 2 years. Yeah,
we appreciate that.
Okay.
But actually, if this would be a real problem, I think it would have been outlined many times. So this is a very rare observation. So everybody of us has such experiences, but it's really, I think, but you need to know how to deal with it. Yeah. Absolutely. Are there questions from the audience, Mario?
Yes, we have a lot of questions for Paul. So the first one is, you say that you use a balloon guide catheter after stenting. And the question is if you usually go through the stent always with the balloon. Is this a normal maneuver or not?
Yes, usually I go with a balloon through the stent, and this is another cause for problems, because sometimes the balloon is damaged afterward, it leaks. But yes, normally I try that. So, of course, normally I try to avoid stenting in the beginning today, as Franziska proposed. But normally I pass through the stent and inflate the balloon distally. And because when you inflate these weak balloons, for example, the Flowgate or Mercy or whatever you use, when you inflate them close to the end of the wall stent, it's very likely that they rupture. And this is another problem with the stenting before thrombectomy.
Fantastic. Yeah, another question, which is, well, I think you mentioned before, is why not using a distal aspiration catheter in combination with a stent retriever?
I think this is a interesting and an endless discussion. I would say to use just a balloon guide and the retriever, it's my and our habit, no? And most difficult thing is to change a habit, and this is our technique, no?
And listen, this is an interesting complication that mentioned one colleague, Mohammed, and he said that a major complication that I faced in my early experience with MCA first is that I lost the access at the end, and I'm stenting the false lumen, leading to a complete ICA occlusion. Does happen to you guys?
I'm sure that it happened, but I think before we started to stent those lesions or to make at least PTA, sometimes because we were all afraid of bleeding complications after antiplatelet therapy, we very often left those carotids after thrombectomy. And an interesting question is, do you really have to treat this lesion when it's completely occluded? Now, when you open up the MCA and there's good flow, and the proximal carotid artery occludes again, in very many cases, this doesn't mean anything for the acute development of the patient. And interestingly, when I looked at our large series of tandem lesions treated with stenting, we had 5% reocclusion of the stent and of the internal carotid after 24 hours, which is, I think, very much similar in other publications. And we had only 1 or 2 patients, so below 1%, which were symptomatic for this reocclusion. And so I think when you lose the access, which can happen, and you cannot reopen the internal carotid artery, and the MCA is open, so what? I would make a run from the other side when there's good collateral flow, leave it like that. No? So of course this can happen. Yeah.
So if you have this, but be honest, if you have a reocclusion, acute reocclusion, do you go to the contralateral side to do an injection, or do you continue going? Yes.
Yeah. So when you so what's a lesion to treat? The lesion important lesion is the MCA occlusion or the terminal carotid occlusion, and when you have succeeded to make a thrombectomy, which usually works very easy because we have a fresh, nice clot which comes out more easy than an old fibrin-rich stuff from the heart, as we all know. And when there's good collateral flow, you can leave it. So today we tend to treat those lesions with a stent and straightforward, and by getting back from intracranial. We leave a stent there. We only give mono anti-aggregation with aspirin in the first 24 hours, and this we all know that this works. And but if you are not able to cure this lesion of the internal carotid artery, in many cases it's not necessary to do it.
Yeah. Because they had a 99% stenosis the day before, probably, so they must have some good collateral. Exactly.
Yeah, exactly.
How to deal with it. Exactly. Yeah, that's one of the cases where we don't treat images, but we learn more to treat images.
You just have to be brave to leave it untreated.
Yeah, absolutely. Yeah, thank you very much, Paul, and all the contributors, Franziska and Maxime, with these very interesting cases. I think we are at the end of the German hour now.
Yes.
I think I enjoyed it as much as you can enjoy such painful things. and thanks all, and thanks for the invitation. And I wish you, Mario, and all the others a great further conference. Really curious about the cases that come next. Thank you very much.
Yeah, congratulations to the German team. Has been amazing. And by the way, we are doing a voting, after the meeting, after all, to see which one is the more scary one. but I'm pretty sure that maybe the German ones will be a German for sure. Fantastic, congratulations. So next session, thank you very much.
Thank you.
Guys.
Thanks a lot.
Next session is going to be the France team for France, and the moderator is going to be Jean-Christophe Hendrick, and I hope you enjoy a lot also. So, okay, see you in 30 seconds.
Hello, ladies and gentlemen. Bonjour à tous. My name is Jean-Christophe. I work in Brest, France, and it's my pleasure to moderate the French session of the Nightmare Summit. I want to kindly thank the course director, Mario Martinez-Galdames, for all the work. It will be, I hope, a special moment to share with three great speakers: Frédéric Clarençon from Paris, Pitié-Salpêtrière Group, Gilda Karoff from Paris also, Kremlin Bicêtre Group, and we will end with Aymeric Rouchaud from Limoges. We will discuss the case between them and feel free to interact. We will now start with the first speaker, Professor Frédéric Clarençon from Paris, Pitié-Salpêtrière. Frédéric, your turn. Thank you very much.
So, hi everybody, I'm Professor Frédéric Clarençon. I'm working in Pitié-Salpêtrière Hospital in Paris, France. And the name of my case today is The Shortest Way Between 2 Points. Here are my disclosures. So the case is a case of a 73-year-old male who had a past history of blood hypertension and a past medical history of surgical repair of an aortic aneurysm and coronary stenting. The patient was diagnosed with an incidental type 3 dural AV fistula, which was depicted on MRI performed from headache. You can see on this one-weighted image an arterialized cortical left parietal vein, which is better depicted on this sagittal reconstruction of the swan-weighted image. Left external carotid artery DSA showed the fistula fed by the middle meningeal artery, the superficial temporal artery, and also the occipital artery. You can see it on the lateral projection, the MMA, the superficial temporal artery, and the occipital artery, and it was the same from the right side. Here you can see the 4D DSA from the left external carotid artery, which shows clearly the shunt with this left parietal cortical vein. So here you can see the origin of the main draining vein, fed mainly by the middle meningeal artery and with transosseous branches from the left superficial temporal artery. So first we try to catheterize as distally as possible through the left middle meningeal artery, but you can see that there are a lot of tortuosities on this left middle meningeal artery. So we failed to catheterize from the left side. We tried from the contralateral side, but it was also very tortuous, and we had an inopportune detachment of the detachable microcatheter tip. So here you have not to play it like John McEnroe. You have to stay cool.
You can't be serious, man. You cannot be serious.
And you have to use the English philosophy and keep calm and carry on. And even you can also follow the Spanish philosophy and keep calm and run on. So we tried first to catheterize the left meningeal artery but failed due to the tortuosities. We tried also to catheterize the right middle meningeal artery, but also failed due to this huge tortuosity. So we decided to discontinue the procedure, and we scheduled a new embolization procedure. And the strategy was to perform a direct puncture of the left superficial temporal artery and to navigate the dual lumen balloon through this left superficial temporal artery and inject EVOH through the inflated balloon. So here we, of course, shaved the site of the puncture, and we tried first to puncture this superficial temporal artery with a 20 gauge angiocat, but it was too soft, and the scalp is very, very hard, like laser. So we use a 16 gauge angiocatheter, and we perform the puncture under fluoroscopic guidance. So you can see here the puncture of the left superficial temporal artery. Here you can see the connection to the Y connector, and we navigated the balloon through this angiocat. Here, the navigation of the balloon, which was a scepter balloon, a regular scepter balloon, which was navigated very distally. And here you can see the inflation of the balloon. The tip of the balloon is here. And afterwards, we injected EVOH through the working lumen of the dual lumen balloon under balloon inflation. And you can see the progression of the EVOH toward the fistula through the transosseous branches from the left superficial temporal artery. And here you will see the contamination of the MMA and the progression of the EVOH through the origin of the main draining vein. Here you can see the cast of the EVOH, so you have a satisfactory filling of all the feeder, retrograde filling of all the feeders to the fistula, and you can see also the occlusion by the EVOH of the origin of the main draining vein. Here you can see the final DSL run with a complete occlusion of the fistula from the left side. And so the patient went out the hospital without any deficit, with a satisfactory evolution. At day 15, the patient experienced a skin necrosis, maybe due to the huge amount of EVOH, and which led to a skin necrosis of the scalp. And 3 days after, the patient experienced a wound infection. You can see here the infection of this necrosis. And the patient had a local treatment of this wound infection with local antibiotherapy. And finally, the patient experienced a wound healing. So the conclusion of this case is that the shortest way between 2 points, of course, is the direct puncture. And the longest one is the middle meningeal artery sometimes, but also often a Parisian taxi driver. So I would like to thank you for your kind attention, and I would like to thank you my team. I'm very happy to work with them. And here you have some references on this topic. Thank you, and have a good nightmare meeting.
Yeah. So great case. Thank you for sharing. And I think it's the way you sometimes you think it's so awful and you have the ability to change the strategy. And I think you did it very well. I think I will have maybe a few questions if you are okay. Frédéric, please, what do you think are the good indication to use this way of direct puncture of artery of the scalp for this kind of embolizations?
For me, the first indication is when you have sometime an occlusion of the external carotid artery. If the patient had a ligation by surgeon, previous ligation of the external carotid artery, so it could be a good option. The team of Lariboisière published a case series using this technique in patients who had a previous ligation. And the other indication is when you cannot, as in the case I showed, when you cannot navigate in very tortuous middle meningeal artery. I think you have to try first, because sometimes you think you won't be able to cross this very tortuous vessel, and sometimes you succeed, but you don't have to. If it's too difficult, you have to stop and to find another way to treat this patient. And the direct puncture of the arteries of the scalp is a good option because it's very easy to do under roadmap guidance. It's not so difficult.
Okay. I don't know if Emeric or Gilda have question to ask to you.
Oh, this is a very great case, and for sure we need to think about those other options. We have many routes to go, and yes, this is a tricky case for navigation, and doing this puncture on the fluoro and with roadmap, this should be probably the best way to go. I just wonder, in case, so we saw that you managed to do the puncture. If you do it twice or 3 times because it doesn't work on the first puncture, do you think there is a higher risk of vasospasm of those arteries? We know that external carotid has more risk for spasm. Do you think for distal temporal arteries, there is risk of spasm if we don't manage on the very first time to puncture?
Yes, you have a risk of a spasm and risk of hematoma. The same as when you do a radial artery puncture, it's a small artery and you can damage it by several attempts of puncture. So if you fail, you can try to the contralateral superficial temporal artery or the occipital artery. Could be another option, but you have to be very gentle with the puncture. But the scalp is very, very hard, so you have to. It's not easy to puncture the scalp.
Yeah, sure. Okay, thanks.
Gilda, did you want to jump in?
Yeah, just a small comment. Congratulations for the case. It is true that we learn, and because we are doing more and more subdural hematoma embolization, that the middle meningeal artery can be very tricky sometimes, and sometimes just one loop can be tricky to pass. Just a small technical point. Do you think, Frédéric, that puncture under sonography could be something feasible too?
Yes, I think it's feasible. It's the same as for radial artery puncture.
Exactly.
It's very easy to depict the artery under Doppler sonography and very easy to puncture. And it's for the end of the operator, you reduce the X-ray dose that you will receive. So it's better from a radio protection point of view. And did you experience such infections, such skin necrosis, scalp necrosis after embolization of a fistula? Because it was my first case. The patient had the skin necrosis just during the lockdown. So he didn't call me. He called me afterwards, a couple of days after. But I was very scared because with this infection of the scalp necrosis, I was afraid to have like a retrograde infection through the cast of EVOH and to have like a kind of cerebral abscess. So did you experience such skin necrosis? Because it was my first experience like this.
We had exactly the same skin necrosis as you presented, also with EVOH embolization. And which is very important is to have a dermatologist and the proper things for preventing the infection or when you have the infections to help and the healing of this scalp necrosis. We had exactly the same, and it took almost 3 months also as your patients for recovering and total healing. It was quite the same. It was painful for the patient at the very beginning, but then after it was going well. So, and we did not experience any infection also of the cast and retrograde infection. It was just superficial as you presented due to the necrosis.
And do you have an idea why we have sometimes such skin necrosis and why not? Because we do a lot of embolization through the arteries of the scalp, and it's rare to have such necrosis.
Yeah, sure.
Frédéric, there is a question from the audience regarding this topic specifically, and is why not to do a direct exposure or puncture directly the vein in order to give
an option to do a burr hole, but I think it's for the patient it's better to have just a transcutaneous puncture rather than a burr hole. It's more complicated. It's feasible, I agree, but maybe it would be the last resort option if we failed the direct puncture of the superficial artery.
And regarding the puncture, do you recommend specific materials like the ones from the radial, for example, with the short sheath, and the smaller needle, or which material are you routinely using?
In this case, we use the AngioCap, the biggest one, the 16 gauge. But I agree, we could use the needle for the micropunctures that we use also for the radial artery puncture. It could be another option, yes.
I just want to ask a question to the other. Maybe in your case, my point of view, maybe I will test to use something like a proximal pressure cooker and try to inject from quite far away, trying to reach the plaque of the fistula. Do you think about it? Do you consider this way on the first time, maybe on the second time?
It was another option. It was to navigate a dual lumen balloon just before all the tortuous segment of the MMA, and to inject proximally under balloon inflation. But the problem is I broke the tip of the microcatheter. It was the way was not accessible anymore.
And this is probably very risky also, because you can hope that it will reach the shunt point, but you are never sure that you can manage to reach it. And once you have the OVH, you occlude the access. And if this is the only one, you're just stuck. And I think the closest you are from the shunt point, this is the best, probably. No?
Listen, guys, when you are doing a very proximal injection from the, with the pressure cooker or through the balloon, do you prefer squid 12 versus 18 versus Glubrand, diluted? What is your preference for very proximal injections where you need to go farther?
I think Glubrand is probably not the best options, because it would clog just before reaching the target. And if we go with EVOH, whichever the dilutions, probably we need to have a larger amount of DMSO, so it can prolongate your catheter, because the sedimentation of the EVOH will be done after the DMSO. If you have with blocked catheter, blocked flow, you inject your EVOH and it will prolongate your catheter a little bit. This is what we do for tumor embolizations like meningioma, when this is very distal. We try to inject lots of EVOH, and we notice that the first drop of EVOH come after the tip of the catheter finally.
I think for the double lumen balloon, one thing sometimes we do not like is sometimes when you have a lot of pressure in front of you, is going to slide back, and you have to inflate, and sometimes you don't know where you are going to stop to inflate, trying to avoid the kickback and the sliding back of the double lumen balloon. And sometimes that's why in this kind of case, if we have to try from far away, we tend to prefer to use one pressure cooker, because here you are like fixed on your position, and you can go and inject the EVOH. For the kind of EVOH, I think in your solution, in your very cases, the field is something like white, the other one are all black. And when you are working just at the level of the skin, I think it's a great choice you made to choose the field, because of simply the color, and you want to avoid to have a mark that will follow the patient whole life. I don't know.
The reason why we used the field, it was to avoid the tattoo of the skin with it was in the air, so maybe it won't have been a big problem, but it was to avoid such inesthetic tattoo.
Good point.
One point for you guys, because if you are far away from the target and you use a dual lumen, did you ever experience your balloon getting stuck, and how did you manage it? Because I think it's an important point too.
We had this problem with the low profile dual lumen balloon, because the connector for the Onyx is not, there is a gap between in the hub, and sometimes you have some Onyx which is being hardened inside the hub, and we had two cases of occlusion of the lumen of the dual lumen balloon, the working lumen, in the hub, due to this poor connection between the connector and the hub of the low profile dual lumen balloon.
And what about the distal tip? because I don't know if the question is about distal tip entrapment, right?
The distal tip trapped.
For us, we have the experience to have sometimes EVOH behind the balloon and sometimes quite a lot of EVOH behind the balloon, but we were not with the low profile one, but with the double lumen, for example, the scepter normal size. We never had trouble to get him to pull it outside the patient, never stuck. It was quite easy always to withdraw the double lumen balloon, even if sometimes you have material behind the balloon.
We have a couple of cases with Stratman, and that's why we select the short nose version to have less distal tip, right?
And especially when you treat a brain AVM, you have to be very careful not to have your balloon trapped because you are pulling on a pial artery, which could be a big problem sometimes.
Very scary.
Okay, guys, maybe it's time for us to give the talk to Gilles Dakarov, and we will talk after about this case. Thank you.
Thank you so much for the opportunity to join this exciting meeting. My name is Gilles Dakarov. I work in Paris in Bicêtre Hospital. So let's have a look at this complex case. The patient is a 60-year-old female. She was presenting moderate gait disorder for a few months. She was admitted for an acute left hemiplegia, and initially Glasgow Coma Scale was 13. This is the MRI showing a vascular heterogeneous 6 centimeter mass. You can also see a temporal cystic lesion and a lot of edema. There is a 10 millimeter mid. Symptoms improved under steroid therapy. We did an angio on the first day, showing a very large serpentine aneurysm, almost completely thrombosed. There is a lot of mass effect. This is posterior circulation, not a lot of collateral flow. This is the 3D rotation. We'll go to the subtracted view. Lateral view. So the MCA, the M1 segment of the MCA and the bifurcation are displayed. Visualized like that. We decided to perform a balloon test occlusion using a sensor balloon in the lower MCA branch, like that. This is the positioning of the balloon, and this is what the angio looks like. This is to confirm the proper position of the balloon. Only the lower branch is occluded. This is EP. And you can see that there is a delayed filling of the anterior frontal area. Not much circulation from the posterior circulation, not much collateral flow. This is left carotid, some collateral flow through the econ. Then to maximize the collaterality, we did a dual injection, both carotid at the time. And you can see the delayed filling. Finally, we did an external carotid injection to discuss a potential bypass. So this is the early phase. The aneurysm is not seen anymore. A few seconds later, you can see delayed filling of this area. But when we did the dual injection, you can see that it's only a slight delay, and all the branches are completely filled retrogradely. As you can see here. So what are the options? I don't believe that an en bloc surgical resection was an option here. Should we go first for a coiling of only the thrombus blood flow communication? You can see that there is a well-seen path between the blood flow circulation and the thrombus, but probably occluding only this small segment wouldn't solve the evolution of the aneurysm. So should we go for an MCA occlusion? Prior to that, I discussed the case with all the open surgery team for the possibility to perform a bypass first, a marsupialization of the temporal cyst to decrease the intracranial pressure. I asked for a craniectomy before the case, or at least a shunt. But the answer was that it was not an option, and we had to manage the case only with endovascular options. This is what I did. We did a coiling retrogradely of all the aneurysm from the end of the sac up to the bifurcation. This is to confirm complete occlusion of the aneurysm. Angiographically, everything looked fine. Slightly delayed filling, but not that bad. The immediate post-op evolution was very good. The patient was almost perfect, clinically stable, normal consciousness, and only the slight left paresis that was already seen before the MCA occlusion. So we were quite happy, and the patient was completely fine. The next day, in the morning, a surprising call from the ICU to discharge the patient to the ward. So, of course, we said no, because we knew that the evolution could be bad because of an increase of the edema. So we even joked about it in the department, and we said, no, the patient has to stay in ICU. 2 hours later, frightening call, because the patient presented a complete hemiplegia. 10 minutes later, there is a decrease in consciousness. 10 minutes later, there is a right mydriasis. So the patient went to the CT scan. As you can see, there is no bleeding and there is no infarction. The amount of edema is quite similar, but there is a slight increase in the midline shift. 20 minutes after the CT scan, the patient is presenting a bilateral mydriasis. Mannitol was injected and the patient was scheduled for craniectomy. Unfortunately, it took some time to organize and to be performed, and it was not finished later than 6:30. On day 2 post-op, this is the CT scan. Glasgow Coma scale is 11. The patient presents a complete left hemiplegia. This is the occluded aneurysm. Contrast in the thrombus. Still some edema and some cortical bleeding. Progressively, the clinical evolution improved. The clinical situation improved. The consciousness went back to normal, but the patient was still presenting a complete left hemiplegia. A shunt had to be performed because of hydrocephalus. And this is the last CT scan. So what did I learn with this case? First, that you have to discuss the case with all the colleagues that will be involved in a complex case. For example, the physician in the ICU was obviously not aware of the potential complication and the speed of the complication, and maybe was not ready to react as fast as needed. You have to be prepared to all scenarios. In order not to waste any time, for example, you have to organize who's going to perform the craniectomy if needed, which room is going to be used, who's going to be the anesthesiologist. All has to be determined prior you perform your case. Finally, sometimes if you deeply think you know best, then maybe you know best. And here, the craniectomy, I think, should have been performed before the MCA occlusion. So I think sometimes maybe you need to take more time to discuss with your colleagues. Maybe you can have a second discussion, and maybe you can all agree and do what is best for the patient. Thank you so much for your attention, and let's discuss this nightmare case. Thank you.
Thank you, Gilda. Very amazing case, very impressive. We do not want to have this patient every day, for sure, but not so infrequent case with very important mass effect. I think maybe before giving the opportunity to talk, I would just ask, what's the definition, exact definition of a serpentine aneurysm to your point of view?
Yes, Jean-Christophe, thank you. Because large aneurysms are not that rare, but serpentine aneurysms are very rare. In fact, it's less than 0.1%. They are mostly located to the MCA artery. And so it's a giant aneurysm, more than 25 millimeter. It's mostly thrombosed. And inside, there are tortuous vascular channels, which are intrathrombotic pathways, but they are not the residual lumen of the parent artery. There is no endothelial layer. So we don't know exactly the mechanism of formation of those lesions. Probably some report the possibility of repeated intramural bleedings. So they can bleed for sure, but most of the time the presentation is like that. It's progressive mass effect, and that can still be fast. And so, yeah, tricky lesions to manage.
I think from an endovascular point of view, I think you did what you have to do. You occlude the serpentine the thing like in two spots, at the distal and proximal and the whole length. We can see also that the patient was not so stable that it seems, because it goes very fast at the end. Sometimes every 10 minutes you have worsening of the clinical symptoms. Of course, what really matters is what you talk at the very end is like the place of preventive craniectomy. Do you think when and how a preventive craniectomy should have been performed in your very case?
Because I think in this case, because you can see some cases in the literature, and some have been managed surgically. So, of course, the morbidity is not low. It's around 30%. We should keep it in mind. But in some cases, were described first a bypass, the removal of the lesion, then the reconstruction of the artery. But I think the point that we missed was the patient was on the edge. The midline shift was more than 10 millimeters. So the patient was one drop away from catastrophe. And so I think there were, I don't know the solution, the ideal solution, but I think we needed to at least decrease the intracranial pressure first. So if you can remember, there was a cyst. Maybe we could have acted on the cyst, or at least place a shunt. Maybe the craniectomy would have been ideal, but really, I think the surgery team was a bit afraid by the lesion and by the bleeding risk. But I think the bleeding risk was not the most important risk. So I don't know. I'd like to have your opinion on that case.
I just want to talk with Frédéric and Aymeric and say what they are thinking with this case and the management and the way they manage this kind of thing in their hospital respectively.
Thank you, Gildas. It was a great case, a great nightmare. I have just one question. The packing of the coiling seemed a little bit loose. Are you sure that there was not a faint feeling of the artery you occluded? Especially, did you control the external carotid artery to be sure that there was no, I don't know,
we did. There was no feeling, and the packing in the middle of the lesion was quite loose. But I can tell you that the final length of coils was quite impressive, and the proximal part, I was very cautious on the proximal part, was very, very tight. So in the middle it was loose because we said maybe that's not the main goal, but proximally it was. I did not want to stop before it was completely occluded, and I think one sign that could reflect the occlusion was, I think there was a slight increase in size of the aneurysm because of the thrombosis, the thrombosis of the channel, and it increased like some pressure.
Okay. And what was the anticoagulation regimen you did? It was you left the patient under full anticoagulation after the procedure, I guess, or what did you?
We did not. No, we did not. And so it was full heparinization during treatment, but then we stopped.
Okay. And maybe it could have helped to slow down the thrombosis. I don't know. It just.
I don't know because the aneurysm was trapped. So I don't know if there was room for heparin to stop inside because it was trapped distally and proximally, but maybe.
And just a technical question for the proximal occlusion of the parent artery, you used a regular microcatheter or a dual lumen balloon to have a very precise occlusion. What was your strategy?
I had a balloon, but rather at the beginning to stop the coil mass because I did not want, of course, to occlude a normal branch. And then, as it was straight and going upwards, it was quite easy, and I didn't need nothing to control because the micro was straight and it was like coiling a straight segment, so not tricky.
Okay.
There is another question for the audience. What do you think about putting a flow diverter in the upper M2 branch to divert the flow and not make it occluding suddenly, to decrease the speed of the clotting?
So yeah, that's an option. Of course, we never know, but it would have been like multiple flow diverters. So you would have to put the patient under dual antiplatelet therapy for some time before you get the occlusion. So we should remember that in 25% of cases, these aneurysms, they can bleed. I would be also afraid that it would behave like a large aneurysm that when you use flow diverter and you have a delayed rupture. So I would be afraid of that. Of course, we can also have one when you do a parent vessel occlusion. But I would be afraid that it would take quite some time before we have any results. And as you remember, the patient had some symptoms. So maybe in a smaller case with less symptoms, maybe it could be an option. But I didn't see much of that in the literature.
Okay. I think you made a good choice because you have quite a definite answer to the trouble and that you are able to go on with the further steps without anti-aggregation and so on. So personally, I would do exactly the same after the time of the craniectomy for me is most important in this case. maybe we just a word, Emric, if you want.
No, I totally agree with Gildas, and probably the option of occluding the artery is the best. This is the evolution of large aneurysms with delayed rupture of flow diverter. This is exactly the same mechanism. And despite the very, very tight coiling of the artery, this is quite impossible to know if there is still very little feeding, and maybe there is still active clot inside, and probably when we hope one day we'll have something with steroids, which could be very delivered here to pacify this clot. I don't know if it will be possible, but this would be a great option for large aneurysms or large amount of clot as it is here. So this is a very tricky and challenging case, and thank you very much, Gildas, for sharing.
Thank you. I don't know if Mario, you have another question, and we do not have time, and we are going to listen to Emric for this case, and we talk after. Thank you. Thank you.
Hello, everybody. I'm Emric Rochaud from Limoges University Hospital in France, and I will talk about a case of direct internal carotid access for true PCOM aneurysm management. So here's the medical history of this patient. She's a 75-year-old woman. She's an active smoker. She has atrial fibrillation, and she has a pacemaker for auriculoventricular block type 2. And she also has aortic valve disease. She has been treated for right breast cancer with mastectomy, radiotherapy, and chemotherapy. And she's been addressed for sudden headache, dysarthria, and the right facial palsy. So here is the CT where we can see Fisher-4 subarachnoid hemorrhage with intraventricular hemorrhage. She was Glasgow 15 when she had this CT. And here is the angio-CT initially, where you can see a little bit upper right PCOM aneurysm, but you can see that this is a true PCOM aneurysm. This is not at the origin of the PCOM, not on the carotid side, but very distally on the PCOM, and you can see here the projection of this aneurysm. So here is an overview of the 3D reconstruction of the initial angio-CT, where you can see this aneurysm distally on the PCOM artery, where you can see also the blood of the rupture. Another projection, where you can see this aneurysm is 5 millimeters width. And after the initial CT, the patient went worse with Glasgow Coma Scale 7. She has been intubated and then transferred to Limoges University Hospital, where first she received an external ventricular shunt, and then she has been addressed in the angio-suite for the aneurysm treatment. So here's the first cell we have, and we can see that this is an aortic arch pictal injection, where you can see that there is the right common carotid, which is missing. So then we did a left carotid injection, where you can see the feeding of the right MCA, nothing else special. And then when we inject the vert, you can see that there is also a retrograde feeding of the right internal carotid artery, which is very thin. And on the lateral, then we did the vert, and you can see that there is a total occlusion of the right common carotid, and there is the retrograde filling till the bifurcation of the internal and external right carotid. So there is a total occlusion of the right common carotid, and we decided to do the 3D angio from the left vert. So here is the initial rotation, and you can see some images where we identify the PCOM aneurysm, which is right here, and here is the basilar trunk, And when we saw the projection from the basilar trunk, there were different angles which we thought were not so easy for reaching the target, because it was a tight angle from P1 then to PCOM and then the aneurysm. So maybe we did not do the right choice, but we thought it would have been difficult to do the treatment of this ruptured aneurysm from the basilar artery. So here is another projection. You can see here the basilar trunk, then P1, PCOM, and the aneurysm. So what we decided, because we thought it would have been difficult to go from the VERT, we decided to do a direct internal carotid puncture. So we punctured the carotid under X-ray with a roadmap, and then we punctured just at the origin of the internal carotid artery, which is very thin, just below the mandible. So here is the profile and the AP projection. You can see the wire of the 6 French introducer. And then once the introducer was in place in the right carotid, I did a manual injection, and you can see that there is a huge bleeding. So probably this is one of the wrong things I did in this case, because I decided to go for the right carotid. And in fact, probably because of the very thin caliber of this carotid, there was not anterograde flow. And when I put the anterograde flow with the manual injection, I had the rupture of the carotid and probably of the aneurysm. So it was very difficult to see from where was the bleeding. So when we saw this bleeding, we reversed heparin. The patient received 3,000 units heparin. And also we opened the external ventricular shunt. And we were in a hurry to do the treatment. So we went from the carotid, and without a balloon, because of the very small caliber of the PCOM artery, I went for direct coiling, simple coiling of this distal PCOM aneurysm. So here is the results when we inject from the VERT with exclusion of the aneurysms and preservation of the PCOM artery. Here are some control from the VERT and also from the carotid. So there was nothing missing, probably very low flow on the right carotid. And here is the final CT we had at the end of the procedure. Here is the last CT the patient had, and unfortunately she passed away 7 days after the rupture. So it was a very difficult case for first for the diagnostic of this true aneurysm of the posterior communicating artery. So those aneurysms are called true PCOM aneurysm, which represent 1.3% of total intracranial aneurysms, and they represent 6.8% of all PCOM aneurysms. So they are very, very rare, and they are due probably to the hemodynamic stress, and there is an important role in development of true PCOM aneurysms associated with occlusion of myovessels. And it was the case of our patients, because she had this right common carotid occlusion. There are few cases, but some of them have been reported of de novo aneurysms and rapid growth of aneurysms reported after carotid ligation, specifically in a true PCOM location, and changes in fluid dynamics were attributed to the growth of the aneurysm. So true aneurysms of the posterior communicating artery are a possible effect of collateral circulation in patients with occlusion of the internal carotid artery. There was a case report and literature review about those specific cases, which can be treated with either surgery or endovascular treatment. When we go for endovascular treatments, most of them are treated from the carotid instead of the VERT. This is what we decided to do in our case, but probably because of the occlusion of the common carotid artery, there was this risk, and this is probably why this patient bled when I injected. So they are still rare, but there were also some reports about true aneurysms of the PCOM, which are associated with smaller or hypoplastic ipsilateral P1 segment. This was not the case in our patient, which had the right P1 segment, which was of normal caliber. In the literature, despite their very few numbers, those aneurysms may exhibit a higher risk of rupture than junctional PCOM aneurysms of the same size. So those aneurysms are very rare, but they are more prone to rupture. In this patient, she had this right common carotid occlusion, and probably because of the occlusion of the carotid, we should have preferred going from the vertebrobasilar circulations. Maybe this was not the good choice. So this is open for discussion, and I would be very happy to have your comments and suggestions for better treatment next time. Thank you very much.
Thank you, Emeric, for sharing this quite hard case, maybe for you. And I just want to ask you one very simple question. If you have to do something quite differently, maybe you have to face the exact same case, and what you see as a main point, just you are going to change in your approach, or are you going maybe to do the same and just look that it can go differently? What do you think you may change in the next case?
Probably I should have not punctured this internal carotid artery because of the occlusion, which was since a long time, probably because of radiotherapy for breast cancer. So I did this internal carotid artery puncture, which is not so easy because this is very high. And then the caliber of this carotid was very, very small, and the flow that we could observe was retrograde. So when I injected, I had an interograde flow in a very small artery, and this is probably why this bled. And when I did not have time to do the 3D from this carotid at the time of the bleeding, so I'm not very sure from where it bled, but probably it bled from the aneurysms, but I'm not sure, in fact. There was a huge amount of contrast very close to the aneurysm. That's why I think this came from here, but maybe I don't know. Probably, if I should do again the exact same patient, I would go from the vert. But when we saw the different angulations to reach the target, it seemed to be much easier from carotid. And as Frédéric said, the easiest way to go is the shortest way. That's why I decided to go from the carotid. But in fact, I don't know. Maybe it was for this patient a bad idea, for sure.
And you use a 5 French, a 6 French sheet?
6 French.
And you use
what we do is a 6 French and Fargomax. Or, this is what we usually do, and this is what I did there.
And do you adapt the rate of the injection, or do you inject manually?
It was a manual injection. That's why it was not. I did a small injection before, as I usually do, specifically in this case where I wanted to check where was my introducer. So I did a small injection and then standard run, manual run, and it's happened there. So I did not use any injector for this.
Just one technical question. How do you close the artery at the end? Because it's quite high. To compress is not so easy because you're just...
I did angioseal. Yeah, I used an angioseal. For this patient, it was not the worst.
Okay. Maybe I will ask my colleagues, Frédéric and Gilda, if they have questions.
I think it was a tricky case. It was a very tricky case and challenging. And I think, the approach can be discussed, but I think that anyway, maybe the aneurysm was prone to rupture. And so I think there was no easy solution for this patient.
And what about for me, it was the first case of ruptured real true PCOM aneurysm I saw. Did you already experience some case like this on the distal PCOM and with occlusion also of large vessel, because in the literature this seems to be rare, but something which has already been reported.
We had one couple like this in my institution, but I have a question. I won't say a bad word, but did you consider the surgery, because it's a flow-related aneurysm, and I don't know, it would have been another option, no?
This case was discussed with surgeons. They have no great experience with vascular, and this is not real options in our institutions. Maybe in some others this could have been an option. I don't know if in your place you think the surgeons would have been.
I don't know. It could be we could discuss it, because here it's a flow-related aneurysm on the PCOM, and the PCOM should remain patent because it's filling the distal ICA. So, but I don't know. It's an option.
And so, what about occluding this artery? It was not an option for sure.
But I think it was the PCOM was feeding the distal ICA, so
the PCOM was there was also a supply from the contralateral side, so okay. I don't know if it could have been an option. Usually, I try to preserve for sure because of the perforators of the PCOM. Yeah. But in this case, I don't know if I would have put just a coil at the origin of the PCOM from the vert. It would have been quite easy to do.
Yeah, but I think even
if treatment of the aneurysms, I think it was much easier to go from the carotid. That's why I chose this option, because going from the vert to basilar trunk, then P1, the origin of PCOM, and then this was a 90 degrees angulation without a balloon, I would have been in very difficult situations for managing a selective embolization of the aneurysm. But if we go for proximal occlusion of the PCOM or distal occlusion of the PCOM from the vert side, maybe it could be also an option. I don't know.
Yeah, but I think what you do, what we all do this kind of thing. You want to be intracincular. The aneurysm seems to have one neck. You are able to coil it, and you are not going to go straight away to tell I am going to occlude in front of the aneurysm. I think the real matter is like the hyperpression you put because you have no ability to flow to go back inside the carotid artery, and so what you are injecting is directly related to the rupture site, and there is something like a point very, very fragile that blow.
Oh, this was a real night. I hope I will not have the same.
Emmerich, did you give heparin? I cannot remember, but yes, I don't think it has an impact.
She recited 3,000 heparin at the beginning of the treatment.
After the puncture.
Yes, and we reversed it just at the time we saw the bleeding, and at the same time we opened the ventricular shunt. But
and for discussion, do you think that?
Sorry.
And for discussion, usually in ruptured aneurysm, do you think that giving heparin after the puncture could have an impact on rebleeding or not? Because for us, we don't think so. We would do the heparin bolus just after the puncture, and I've rarely see any rebleeding.
Do it after the first coil.
Exactly.
But I'm most afraid of missing or forgetting to ask for heparin and have clotting than
getting a clot
before going to the target. So that's why usually we do it just to not forget it.
I think for heparin rupture case, sometimes when they have one hematoma, we can see, I think, growing of the hematoma is more usual to see this kind of thing, but we do not experience any rare rupture just after heparin, after the puncture. Here. I don't know if Mario have questions for the audience.
Yes, but the discussion of you guys were very interesting. I don't want to disturb you, but there's one specific question I think is we should mention is, if you had this case, but it was unruptured, would you consider another strategy like flow diversion or similar?
I think the corridor of the PCOM was very small, so if we put flow diverter, it would have been probably on the P1, P2 junctions, because from
they mentioned specifically from P1 to the basilar, just to cover the origin of the PCOM.
Yes, maybe this could be an option. I don't know. After the risk, if there is aspirations to have the opacification of the distal carotid, the risk is that there is still flow on the PCOMs covered by the flow diverter and no occlusion of the aneurysm.
Another question is very important is regarding the mechanism is if you think that the injection for the ICA, because was occluded, create a hyperpressure and they rupture the aneurysm.
This is probably, even if I did the manual injections, which was smooth because it was manual, so I did not use any injector, but this is probably the reasons for a rupture of this aneurysm. Or aneurysm or carotid, I don't really know. But after the occlusion of the aneurysms, there was no increase of the bleeding. So I guess the target was occluded and the rupture point was occluded. So I think it ruptured the aneurysm.
Okay, it's time for me to close the session. It was a really pleasure. I hope you have enjoyed this hour and stay tuned and enjoy the meeting. And thank you again, Mario. Thank you.
Thank you very much. Amazing session, guys.
Thank you. Bye-bye, Mario.
So let's move to the next session, which is from UK, moderated by Dr. Paul Bogal. Let's go.
Mario, hi, how's it going? So it's my great pleasure to be part of this, and it's great for a couple of other fantastic people that I know very well and working with to be part of this excellent program that you've put together, Mario. It's a pleasure for some of the UK guys to be part of this, and already some fantastic cases and great discussions. So without too much introduction from me, I'd like to introduce the first cases, which I think will be shown by Dr. Macalanda.
Hello, everyone. My name is Levansri Macalanda. I'm the clinical lead for interventional neuroradiology as part of the brain group at the Royal London Hospital. I'd like to thank Mario for giving me the invitation to talk and Paul for inviting me as well. Unfortunately, I work with him, but we will talk about the inception of FLOW-T and why necessity is the mother of innovation. So the patient is a 42-year-old female that presented with a one-day history of headache and photophobia. In the CT scan, you can see that there is some hyperdensity within the insular system and Sylvan fissure. When you mag up on the CT image, you can see that there's likely a part thrombosed aneurysm with some sulcal subarachnoid hemorrhage. The CT angiogram showed a middle cerebral artery wide net bifurcation aneurysm, which was mapped in a similar fashion on the digital subtraction angiogram. Because of the thrombosis, we thought it's likely to be dissecting in nature, the etiology underlying it. So on angiography, we're trying to work out the treatment options, and I actually called Paul to discuss the treatment options with him at the time. So simple coiling, we didn't think would work because it's a partly thrombosed aneurysm, and the coils would just float off into the thrombus. If you stent-assisted coil, it's dependent on which branch you can treat, the anterior or posterior branch. A web again or other intrasaccular device would float off into the thrombus. If we flow divert, which branch do you put the flow diverter into, and how then do you treat the other part of the aneurysm? She declined open neurosurgery. So then we had to think of something else, be it a Y stent or a T stent. And after discussion, we thought probably it's best to try and split the bifurcation into two aneurysms. And Paul suggested, if the thrombosis and the stasis is on the anterior ventral portion, which is a dissecting portion, which would normally flow divert. Why don't we try and flow divert, but put the stent flush with the bifurcation? And if you do that, then you've treated the rupture point and the dissected point with the flow diverter and the coils, but then you also leave the posterior branch where you can then just put a simple stent-assisted coil treatment for that. And then you don't cover an M2 branch with a flow diverter and the braid and the mesh braid with that. So we tried it. The Silk Vista Baby had just come out. It goes through a 17 microcatheter, which we navigated into the anterior branch and deployed that flush with a bifurcation, jailing another microcatheter to coil the ruptured portion of the aneurysm. And then we completed the construct with a braided stent, compressing the stent across the neck and then coiling the dorsal aneurysm. And that was the final result, which I was pretty happy with, given what came to. And we named this Flow T as opposed to the conventional T stenting for bifurcation aneurysms. So just some technical points. I initially had to reposition the initial flow diverter 6 or 7 times to get it flush with the bifurcation. And in the end, I erred on the side of protruding into the bifurcation so that I could push, if required, the stent with the second braided stent. Compressing the braided stent at the neck would help the flow diversion effect, I thought. And at 6 months, we had a stable occlusion. There was a normal MRI, there's no ischemic foci on that M2 segment. And there was some mild in-stent stenosis, which you can just see here. And that's what it looked like on the subtracted version. 18 months, it had remodeled further, but again, a stable occlusion, and it looked pretty good for a young woman with a subarachnoid hemorrhage. We looked at this further with CFD analysis, and we modeled 2 different aneurysms. And if we compare an untreated aneurysm with one that has conventional T stenting with just 2 braided stents, there was a 23% reduction in aneurysm inflow. But if you do a Flow T with a flow diverter as the short arm, it reduces the flow by 33%. However, if you compress the braided stent, you get a 63% reduction. So that's quite a marked reduction compared to the conventional T stenting. The second aneurysm we modeled, again, 53% reduction with a T stenting, which can increase up to 78% with a compressed braided stent, and then the flow diverter on the short arm. So in summary, the T stenting is an option for wide neck bifurcation aneurysms. And we've done this with this Flow T procedure subsequently. The technique was originally performed by Cho et al. In 2012, and they used closed or open cell stents. But with the advancements in stents now, we can use low profile braided stents, Baby Leo, and even flow diverters like we did in our case. Aidan and al. Have published excellent early results with a Raymond Roy 1 or 2 of almost 100%. But because we have used the flow diverter, we've named this Flow T. We think it's an advancement on the standard T stenting. And we've published it in the INRJ. So with that, I thank you very much and ask if there are any questions.
Okay, lovely. Thanks for that case, Levan. I think you and I both know this quite tricky and unpleasant case quite well, because there was a sort of phone call I recall of what the hell do we do with this thing? She doesn't want to have neurosurgery. So I mean, I think it was quite a nice. It was a nice case from an intellectual point of view, but I think it was doable only because of the latest technology, and thankfully that we are privileged to have in our department. I think otherwise it would have been extremely difficult. So give us some insights as to how, like, technically that was an amazing procedure that you've done. It was, it's beautiful end result. So are there any tips and tricks on how you could position the Silk Vista Baby so perfectly?
So firstly, it's always better to be lucky than good. I did reposition that Vista probably 6 or 7 times, and it was lucky that with that technology, you can unsheath it almost to 90% and then resheath. But you try and err on the side of caution. You try and put it halfway across the aneurysm neck. So if anything, you can push it back into that branch with the second braided
stent. Yeah, you can bulge the second one. Yeah, okay, fine. And because you've done another case more recently, haven't you, where you managed to get them almost kind of to interlink so that you get the perfect positioning of both of the stents. Was there anything that you learned doing the second case, or anything that you, in hindsight, picked up from the first case to manage the second one and perform better?
It's just really erring on the side of caution and trying to make it, it does foreshorten a lot.
Yeah.
And you know, when you first start, the proximal markers of the stent are in the M1, halfway down the M1, and you think this is the way it's going to be.
Yeah, exactly.
By the time you get to 90%, it's almost done.
Yeah.
I do measure the length of the stent, and I use the Philips software to see, you know, what the nominal diameter will be with that diameter of the vessel. But yeah, it's a lot of pushing and pulling.
Yeah, okay, that's fine. Manu, I mean, I know that you've done like literally hundreds of MCA bifurcation aneurysms, T stenting, half T stenting, Y stenting. You're probably the king of this in the UK, perhaps even further afield. What do you think?
Oh no, please, I wouldn't. Yeah, I mean, I've been lucky to learn this. I learned it from Rene, this technique of T stenting, but I've never used a flow diverter. My complication for flow diverters is very low, only because I don't go beyond the ICA bifurcation. So I've put distal MCA 4 cases and periclosal 2 cases, but never in an MCA bifurcation or AC I've started putting. When there is bilateral A1, A2, I start putting. But this is very good. I mean, I can understand you need to be extremely precise to put that flow diverter. So yeah, I prefer putting Baby Leo, or now the new one's Evo. But yeah, I would try it next time. Thank you.
So yeah, so actually, when Levan and I were discussing this and we sort of worked this out, actually it was kind of that concern that we have, because you know, there's varying literature, isn't it? Some people say, oh, it's fine, but you do always end up with this one branch is jailed, and you're effectively you're dependent upon reduction of flow into the aneurysm through the jailed branch, and if that doesn't work, and that, to my knowledge, there's no way at the moment really of predicting whether it will or it won't.
The only question I want to ask, I'm sure people have asked you this, you know, why didn't you put the flow diverter from the M2 to M1 and put the Leo or whatever you did on the smaller one?
So the thing then is that you're losing access into the vessel. So this way you're putting a flow diverter, you've got basically 48 braids across the neck of the aneurysm, because you're compressing the braided stent as well. So, you know, that 16 braids with compression makes it 32 or 48. So then by the end you have, you know, 48 braids across the neck. And this was the days before, you know, Webb or Contour could do such a thing. And with a part thrombosed aneurysm, you couldn't use intrasaccular device anyway. So.
Yeah. So I think that was exactly the reason that Levan and I sort of deduced this technique, was so that you don't cover with a flow diverter essentially the side branch. And so what we had hoped is that what you could create is a flow diverter at the neck of the aneurysm, but not into the side branch.
Okay.
And so that's why we call it flow T, because from the purposes of the flow, it's similar in some senses into the side branches as just normal, like with a Baby Leo or with an Evo. But for the purposes of the coverage of the neck, actually you've created a flow diverter. So that's also why we started doing some of the modeling on CFD, and that's partly what you see. You do get a much bigger reduction in the flow into the aneurysm from lots of compression of the Baby Leo, but that still kind of depends on the anatomy of the aneurysms and the flow and the branches, which is what we're seeing in the modeling studies actually. So we've just had another paper on that published, and we're currently looking at about 20 aneurysms and going to compare and see if it's doable, and what sort of degree of flow change you get actually. But apart from surgery, we couldn't really think of a very good alternatives, certainly from what I could see of the aneurysm. And, Levan was the one that did the procedure, but it almost had like two separate aspects. So, neck stent, contour, all of these sorts of things, they're not really suitable. Mario, you're on mute.
Sorry, I am mute. Yeah. Sorry. So congrats, because the treatment was super elegant, beautiful reconstruction. So the question is, if for this flow T you use 2 flow diverters, 2 Sylvista baby instead of baby Leo plus, so you use 2 flow diverters, do you think it's necessary to add coils, or you can use it only flow diverters in these distal locations?
Used 1 flow diverter and 1 braided stent, which I compressed.
No, 2 flow diverters. So exactly the same configuration as you showed before, but instead of baby Leo plus Sylvista baby, use 1 Sylvista baby and the other half also Sylvista baby with no coils. Do you think it's feasible? What do you think about it?
I'm not sure it would work as well. You're taking all the risk of putting a flow diverter across a bifurcation aneurysm and relying on the collaterals without, so the increased risk of stroke is there, which is why we tried to use 1 braided stent and 1 flow diverter, and the compression of the braided stent to give that flow diversion just at the neck, but leaving the branch open. Even with the reduction in flow, there was a 70% reduction on the CFD models, but even with that, I wouldn't be comfortable myself. I'm just naturally cautious. I'd still put coils in the aneurysm. So then the aneurysm's gone, it's dead. So you don't need to worry about that. And the recanalization rates are a lot less.
This is another question from the audience, but I think that you mentioned before, is how to predict the proximal foreshortening of a flow diverter. This is the most complicated part here.
Yeah, that's really difficult. I mean, you've done similar things in the PCOM, haven't you, Mario, with the Sylvista? It foreshortens a lot, and measuring the diameter of the vessel that you're putting it into, and we have the Philips software where you can measure, you can give an idea of how long the stent will be for a particular diameter of vessel. But even with that, there's a lot of playing, pushing and pulling to try and get it into place. And I try and err on the side of caution to try and push. If needs be, you can push the stent back with the braided stent, the second stent.
And it's another question. What is your selection in my MCA bifurcation aneurysm? Do you prefer wire stenting, regular wire stenting with laser cut stent, or this type of hybrid configuration?
I prefer hybrid configuration to laser cut, because I always think that laser cut, you have some struts in the vessel itself. So you're never going to get true endothelialization. And now, this was a particular case where you had the part thrombosed aneurysm as well, where you can't put an intrasaccular device, but for a standard aneurysm, an intrasaccular will probably work just as well.
I think personally, Mario, there, when we have ruptured MCA bifurcation aneurysms or something, and the only option there is to do like a T or a Y stenting, often I'll use something like the Atlas personally, just because there's a little bit less metal. So the concern there is thrombosis, acute thrombosis or what have you, which leads on to a different subset of questions actually of, once an aneurysm is occluded, whether it be clipped or whether it's coiled satisfactorily, should we actually consider putting people on antiplatelets generally, because of the growing evidence around microthrombosis and the effect that prasugrel, tirofiban, et cetera, have on prevention of DCI.
In the first session, Paul, in the first session, one of our colleagues, Pedro, presented a thrombosis of the baby Leo in half T configuration, and he removed with the Catch Mini. So do you have the experience to remove this type of stent, especially Manny that have a lot of experience with that?
I've personally not had the problem to do it. I don't know, Manny, if you've had any thrombosis of Y or T stent.
So I've done now close to 200 stents, Leo stents. I've used that. My first 4 cases, I did 3 of them had thrombosed, and it is purely technical error. And the way I put the stent was wrong, and I had to retrieve 2 of them, and 1 I had to accept that situation. So after that, I've never had a situation where I have to retrieve a stent, but I've had cases where there was thrombus forming and I've treated with, IV injection to reduce the thrombus, but I never have to retrieve a stent. No.
Yeah.
What was technically wrong with your first few stents, Mani, that you've changed?
To show you, it is pretty disappointing the way I put it, because I was used to, when I trained, I've only used laser cut stents. So laser cut stents, you just have to pull the catheter and it's open, you know. So first, when I used this braided stent, at that time, it was 2009 was my first case. I was just started as a consultant, and I did the same. And Leo, you have to see the braids, and that was a G machine. I couldn't see it properly, and I kept blaming the machine, you know. And then it happened a second case, and actually I went to Shimon in Tel Aviv, and then he showed me the technique, how to view this. It's like a DNA, the strands you can see, so how to predict where it lands, you know. That was helpful, and Rene also helped me a lot. But the first 4 cases, 3 was a disaster, you know. And luckily 2 of them I could take it out.
For the next year, Mani. Okay.
Yeah.
There is no more questions here for the audience, Paul. So
lovely. All right. Thanks very much. Well, I guess we'll move on to the next talk then, which will be coming from Mani, which I think is all about embolization, transvenous embolization of an AVM, if I remember correctly. So another important topic that's coming up more and more and more. So look forward to this one. Actually, I'm sure I'll have lots of questions about this one. Okay, great.
Hello, everyone. My name is Dr. Mani Puthuran. I work as a consultant interventional neuroradiologist at the Walton Center in Liverpool, UK. Today, I'm going to talk about a complication that occurred post venous embolization of an AVM. So this is a 19-year-old female patient who presented with a history of migraines. This has been going on for several years, but progressively the frequency of the migraines started increasing. So as a routine check, she decided to have a MR scan. She's finally a university student in our neighboring city in Manchester, where she was doing forensic sciences. There was no significant past history or any family history of subarachnoid hemorrhage or AVM. And the MR scan showed an incidental right arteriovenous malformation. So the patient was initially seen in our referring hospital, where she was given some idea of the abnormality, following which she was seen in our clinic with her parents. So we have a combined clinic with a neuroradiologist and a neurosurgeon during these consultations. We then discussed various options of management, which included conservative management, embolization, surgical resection, and radiosurgery. We also made patient aware of the Aruba trial, its significance, and its pitfalls. We felt that for her age, all 3 options were suitable for this patient, which means that embolization, surgical resection, and radiosurgery. And so these were discussed with the patient. So usually our practice is that we allow the patient and the family to think about what we have said. A full letter of the consultation goes to the patient. She's given time. And between a month, 2 months later, we bring the patient back for further discussion. So a second clinic appointment was made a month later for the patient to consider all options and to discuss management options. And the patient decided for endovascular embolization. So initially, the first step is we do an angiogram and a superselective angiogram, and this is the arteriovenous malformation supplied by the branches of the callosal marginal artery on the right. And you can see a prominent cortical vein draining it into the superior sagittal sinus. So here the key findings are there is a good venous drainage, single large venous drainage. But the problem here is not the arterial supplies on Passot feeders from the callosal-marginal vessels. So these are not vessels you can actually plug and pressure cook. My initial plan was to occlude this artery with coils, jail a catheter in this and in the other artery, and then reverse inject from both artery and vein. But during the procedure, we decided to go for primary venous embolization. So before that, I did a balloon occlusion test. I put a balloon in the A1 and injected the right ICA, and this shows good collateral supply. So we knew that you could sacrifice that short segment of the artery, the diseased segment of the artery, and the patient will not have any significant issues. So for venous catheterization, we have a standard practice where we use a Fabuki 7 French after puncturing the jugular. We place the Fabuki over a 5 French catheter. We found that to track the Fabuki is very difficult. So the Fabuki is taken over 5 French, brought very close to the origin of the cortical vein. So this position is not satisfactory. If you have it in this position, when you try to get into the artery, you'll always have prolapse. So this is the ideal position where you have the Fabuki very close, and we make a bend to the Fabuki, track it into the cortical vein, and then you can see we use a J wire. We found that very easy with a J wire to track the Apollo catheter. So the standard practice again is that either we use 3 Apollos or 2 Apollos and headway. The Apollos are for injecting squid, and the headway for coils and for glue injection. So once we had this in position, that is what we have, a distal tip of the Apollo, a second Apollo here, and that is where in between here is the tip of the headway catheter. So with the headway catheter, initially we put coils, and at that time we asked the anesthesia to slowly bring the pressure down. So by the time the coils are put, the pressure is usually about 60 to 70 millimeters of mercury systolic. Then what we decide to do is in the middle catheter, middle Apollo, we start injecting 18%, squid 18. Usually what we see is immediately it starts reflexing back. Once it's reflexed back into the coil mass, we inject glue 50% through the headway catheter, and that is our plug. Once the plug is formed, the plan is to inject squid 12 from the distal most catheter. So before doing this, I realized that the on-passat feeders are very short. So as soon as the squid gets into the artery from the vein, there is a chance it can immediately get into the callosum marginal, the parent vessels. So this is significant. And this is why I had the initial idea of occluding this selectively with coils before injecting, but we decided to go ahead with trying and putting a balloon. So 2 balloons were placed in both those vessels. These were Eclipse long balloons, inflated it to prevent reflux. Soon after we started injecting, we started getting some reflux around the balloon. At this time we waited, we injected a bit more from the venous side. But I always felt with this that in this particular case that there was not enough density in the penetration of squid in the arteries. Ideally, we like it to be very dense. That means the artery is well occluded. But we decided to stop because, as you know, with balloon, you will not be able to control fully the reflux of squid, and it was tracking on the side of the balloon. So we stopped. When we did the angiogram, everything looked fine. And this is our standard protocol where coils are inserted by a headway catheter to form a proximal plug. Second Apollo, we inject squid 18, and when it reflects, we inject 50% glue. Once the plug is formed, the squid 12 is injected via the distal Apollo catheter. We have now done 23 cases in this manner. But apart from 4 or 5 cases, all the other cases, we had both arterial and venous control for the injection. So as you can see, we found it difficult to control the reflux into the parent vessel. Angiogram looked fine, it looked occluded, but the first mistake I feel was that we should have, at the end of the procedure, selectively injected both these arteries, parent vessels, to make sure there was no small, on-passat feeders still going towards the AVM. So that we didn't check. We were happy with this result. Unfortunately, when the patient woke up, she was fine, but 24 hours later, she started having gradual increase in her headache. Initially, I was not too concerned because sometimes when you inject squid, and especially with this venous catheterized nipple, they can get headache. But the following day, the headache was worse, and she was complaining of a headache which is in the range of 8 to 9 out of a score of 10. So we did a CT scan, and this was an unfortunate event. She had a bleed. So this was extremely lucky for her because of the location, but if this was in the ganglionic or an eloquent area, that would have been a disaster. Now the biggest issue was, how do we control this bleeding? So we reduced the blood pressure to about 110 systolic and maintain it for 24 hours in ITU. She was not intubated because she was compos mentis. Following that, we repeated an angiogram, and it was still, the vessels look completely occluded. The AVM was completely occluded. So here we are actually relying on luck that it doesn't bleed further. A week later, then you know that it's not going to bleed. The AVM will be completely occluded. So, as I said, the patient had severe headache 2 days post-procedure, gradual onset, no focal deficit, but she was getting drowsy, not to the extent where we had to intubate her. 2 days monitoring in IT with systolic of around 110. By 1 week, she was improved and she was discharged 10 days post-treatment. And after that, the headache almost completely disappeared. Now, the learning points is what the mistake is that we always tend to have good arterial control when we do transvenous embolization, unless it's a very tiny deep vessel where we know we can completely occlude from the venous side, but we still have an arterial catheter. So in this case, using a balloon, I think, was not the right idea. Patient selection is important. So we could say that because of these on-pursuit feeders, probably surgery would have been better rather than going for transvenous. I still think transvenous is good in this. If I was doing a similar procedure, definitely I would occlude that short segment of the callosum marginal, maybe even leave a catheter in there, and then before doing venous injection with SQUID. You could argue whether I should have used SQUID 18 because SQUID 12 will, move very quickly into the arterial side, but SQUID 18 would have been more controlled, but I don't have the answer for that. So thank you very much.
Paul, you're mute.
Sorry, on mute. Someone has to do it first. That was an amazing case. Thanks very much for that, Manny. We've not got very much experience, or I personally don't have very much experience of transvenous embolization of AVMs. A lot of our AVMs actually we send for Gamma Knife in large part because of the Aruba study, really. So what would you say are some of the learning points here to people like myself who haven't done very much transvenous AVM embolization?
I still think if you can do something transarterially, that's still the safest. Now we have changed our technique and protocol where we only accept cases where we can go for complete occlusion. And we try to do it in 1 or maximum 2 sittings. I think when we audited, 72% of our patients were 1 sitting. So that's one thing we changed. So if you're going, if you think you can do it transarterially, do it transarterially. But as you move forward, you will soon find cases of deep AVMs, small AVMs, where the only way to do is transvenously.
Yeah.
But the problem with transvenous, unlike transarterial, is as soon as you occlude the artery, occlude the vein, there's no backing off. You're stuck there. So either you complete or not. Whereas the artery, even if you occlude the artery and even if you don't inject a SQUID, you can stop anytime because if the vein is not filled, then it's not a problem. But once you pressure cook the vein, then it changes the game. So now we've done 75 cases, I think, of which we have had 4 bleedings, of which 2 were significant. And comparing the proportion of transvenous, now it's, I think, 24 cases, we've had 2 bleedings. This patient recovered completely, but second patient, we had a bleeding that was catastrophic. She had to have surgical evacuation of blood. And the problem with transvenous is that you have to understand the arterial supply completely. If you miss any artery, then you're just depending on luck. So I'm scared. It's scary, transvenous.
So that's interesting because that had always been my interpretation of you have to really understand which feeders are going into which compartment and then draining into which vein. And and that I think can also alter obviously as you're embolizing and blocking off different compartments and things. Because to me, they don't necessarily always seem, the compartments don't always seem entirely separate, let's say.
And so draining veins properly also. How many draining veins are there?
Yeah.
Recently we had a case, a small AVM in the CP angle region. Obviously surgeons wouldn't want to operate. This was a patient who had bled. So we went transarterially just to get the control angio. And then transvenously, as soon as I reached the vein, I realized there was a separate vein filling, draining the AVM. And then you're stuck. And believe it or not, I had to call Rene Chapeau on his mobile FaceTime to see, because I had an idea of what to do, but I wasn't sure. So that's the problem with these, you're stuck, suddenly you're there and you think, my God, what am I supposed to do, So planning is the key. And the amazing thing is that I've done one case on the tectal plate. This is a local lawyer we had been observing him with a tectal plate AVM for 6 years and finally bled. And then I treated it no way you can treat it arterially. So I treated it transvenously and he's fully recovered, but it is scary.
Yeah. No, I think it was the stuff that I said was basically based on some of the cases that Rene showed a couple of years ago, I think at ABC Win. And he's showing tiny little compartments and you can see the veins and he can see the veins. And you're just thinking, I mean, this is amazing stuff that he's doing. And it's, it's really good for you to be able to access that kind of knowledge.
Annie, can I ask a couple of questions?
Sure.
So when you're going transvenous, is there an upper limit of volume of squid that you can inject? Because you got to take the whole AVM in one sitting. So, very large AVMs.
Yeah. So again, large AVMs, I wouldn't go for it, So that's the key is patient selection. You go for AVMs which are small, compact. I've seen Rene do large AVMs where he partially goes from the arterial side and occludes majority of it, then transvenously. I've not done those. So I go for AVMs that are very deep. And I always make sure the surgeon doesn't want to operate. This case, the surgeon could have operated. So this is why I'm saying this was a wrong choice of patient. I think, probably retrospectively, whether the surgeon could have operated, But the ones I've gone for are deep ones. Or I've also gone for ones where I knew if I couldn't get transvenously, I could get transarterially. So we had a backup plan. I think that is so important because if you have bleeding in your first 5 cases, 3 of them bleed, then emotionally you're upset, and you can't continue that. For me, even having 2 bleeding transvenously in 24 cases, it's scary.
Can I ask one other question? You said in retrospect you'd coil the callosum marginal, but I thought if you're going transvenous, the purpose is that you're preserving the parent vessel and you're just taking the en-passant supply. So aren't you just...
So that's what I'm saying. Again, that is not the right selection. That's a mistake I made, So that's why I'm saying that probably the surgeon could have preserved the vessel. So as you can see, I also had a backup plan because I did a occlusion test to make sure there's good collaterals. So I knew if I ran into trouble, I can occlude that parent vessel. So those are things. Always have a plan B or plan C before you embark on this.
And have you used the Septa Mini in any of your cases to sort of halt inflow, Manny?
So I've used it in 2 pediatric cases. The problem with Septa Mini is that at one stage it will back off. It will never hold that pressure. After some, it will come back. I have greatest regard for Rene.
Manny, we've lost you, Manny.
Hear me?
No, we can hear you now. Yeah.
So Rene has taught me a lot. So I'm not trying to praise him, but I have to admit pressure cooker technique is the best, So I wouldn't do it without that. And this getting 2 catheters, a lot of people say it's difficult. No, it's not. Once you have 1 catheter, the second one is easy.
Especially with newer equipment.
Why you had a third?
Sorry.
Yeah.
Can I ask why you had a 3rd catheter? Because you said 2 Apollos and a headway duo.
So this is nothing new. This is all I copied from Rene. So his technique is using 3 Apollos. So you inject squid 12 with the distal most, squid 18 with the middle, and the proximal most you put coils for the plug. And the first case, not the first case, the 4th case I did, transvenous embolization, I made a mistake where as soon as I injected glue, it reflects back. So it is very important to get the blood pressure systolic to about 60 and have that system of doing it. So the first case we did in 2015, my transvenous, Rene had come here and done one, but I don't think that technique was fully refined. So after that, I learned it from him and we follow this technique.
Do you have any experience of adenosine-assisted asystole or any of those sorts of things as well? Because there's a few papers coming out and a few more people talking about that now as well.
Yeah, I've heard that from Adnan Siddiqui. But even to get this systolic to 60, the anesthetist will freak out.
Yeah.
Yeah. So finally, I found an anesthetist who has worked for ophthalmology surgeons.
Okay.
And she said she was very calm. She said, no, she's done it in the past and she's not bothered, So I used that and I got the other anesthetists to learn from that. So now they're okay. But the first time I still remember when Rene came here in 2015, they created havoc, when he said to get it to 60.
Yeah. I think we're quite lucky. We've got some cardiac anesthetists who are like, we can do whatever you want. It's not a problem.
You don't have cardiac.
Yeah, but then some of the others are like, no way, I'm not doing this. So it's quite tricky actually. Depends on your anesthetist of the day, I guess, right? Yeah. So are there any questions, Mario?
No, I mean, there are some philosophical questions about why do this instead of radiation or surgery, which is easier. So we may discuss a lot, I mean, as you mentioned before, but thank you, Manny, for showing this elegant and beautiful technique. Thank you very much.
Lovely. All right. Well, I think that wraps up the second talk from England. Thanks from Liverpool. Another famous person, just like the Beatles there. I think you're probably one of the neurovascular Beatles in England, I think. And I think the last talk will be coming from me. This was a bit of a nightmare from me, but for not just from a procedural point of view, but actually from, again, patient selection, background medical problems, how do you deal with all of these things? And often those are the worst kinds of nightmares, at least in my experience, not the neurovascular aspect. Okay.
Hello, everyone. My name is Dr. Paul Bogle. I'm a consultant interventional neuroradiologist based at the Royal London Hospital in London, United Kingdom. Thanks, Mario, for inviting me to this fabulous conference that you've organised. And it's a pleasure to be here and present this nightmare that I had to deal with some time ago. So I'm going to give a brief clinical history, my treatment strategy, and then the outcome that we've seen in that particular patient. So this was a 35-year-old female patient who presented to our emergency department with a sudden onset of very severe headache. She had a complex background medical history. She was known to have Marfan syndrome. She was found to have a type A dissection, which was felt to be chronic. This was discovered at the time of the SAH, actually. Two metallic heart valves, both the aortic and the mitral valves, had been replaced. She'd had a previous Bentall repair of the aortic root, and you could still see aneurysms at the origin of her coronary vessels. She had a very poor ejection fraction. It was just below 20%. And because of the metallic heart valves, she was warfarinized. So that's just the background in this young lady. So given the sudden onset of severe headache, obviously a subarachnoid hemorrhage was suspected, and this was confirmed on the plain CT examination. There was a very heavy blood load, particularly in the posterior fossa and fissure 3, with some intraventricular extension as well, which was leading to hydrocephalus. Initially, when she presented, she was GCS 14, but this suddenly dropped to 9, and then subsequently dropped to 3, and she had a respiratory arrest. She was intubated rapidly, and it was noted that throughout this period, her pupils remained reactive. An EVD was inserted as fast as possible, and the neurosurgeons reported that it appeared that there was a considerable pressure because the CSF came out rapidly after insertion of this EVD. So we went on to perform CT angiography of the intracranial vasculature, but also it was noted that this dissection could be seen, as you can see by the green arrow here, a dissection flap, and here's the dissection flap. And here are the metallic heart valves, and you can see just about here's one of the aneurysms at the origin of the coronary vessels.
So complex anatomical problems involving the aortic arch as well as the heart. What we also saw in the extracranial CT was very tortuous vertebral arteries bilaterally, and possibly a stenosis on the CTA at the origin of the right vertebral artery. Intracranially, we could see again what looked like a very markedly irregular and sort of dilated as well as stenosed appearance to the left V4 portion of the vertebral artery, which was felt to be a pseudoaneurysm, a sort of very classical appearance there. And we also saw a left posterior communicating artery with a good P1, no definite right-sided posterior communicating artery. No other intracranial abnormalities were seen, no other aneurysms, etc. So it was felt that this was the most likely cause to be the subarachnoid hemorrhage. So the issues that we had to consider were she was a very young patient, very poor cardiac function with a very low ejection fraction, a dissected dominant left vertebral V4 segment, resulting in a very large blood load that required emergency EVD insertion after a respiratory arrest. There is a left-sided PCOM, and there was also presence of a right vertebral artery, but there's no real way to assess whether or not those would be able to supply the basilar and the posterior circulation if we chose to use a deconstructive technique to deal with the dissection. So essentially this came down to a risk-benefit call of deconstructive versus reconstructive treatment options. So I opted for reconstructive, obviously because of the dissection and because of the Marfan syndrome. I was reluctant to do full cerebral angiography, and I don't think it would have been possible anyway. There would have been no access to the left vertebral artery from the right radial artery. And so assessment of the left radial artery with ultrasound was made, and it was found to be very small, certainly not conducive to a radial approach. Therefore, in order to minimize the risk of trauma and dissection, I used ultrasound guidance to initially do a micropuncture access to the right common femoral artery. After a check angiogram to make sure that the vessel was okay and we were in a good position, this was upsized to a 6 French short sheath. Following that, using a benchmark catheter tracked over a vertebral catheter, we accessed the left vertebral artery, and this is what we faced. So I managed to carefully navigate the benchmark into this sort of proximal, distal V1, proximal V2 portion, but I was reluctant to try and take any more of the more distal curvatures for fear of causing dissection and then potentially losing access actually more distally. So the benchmark catheter was placed relatively low down. All the time, rather than doing machine injections and pump injections, all injections were done very carefully, very slowly by hand to minimize the risk of iatrogenic dissection. Because of the low position of the benchmark catheter, what we used at the time was what we had on the shelf was a 4.2 French Fargo Mini, which tracked up as high as we could into the distal V3 portion in order to provide some extra stability for when we decided to do the flow diverter treatment. This is just a fluoro loop of what we saw at the time. As you can see, a markedly irregular pseudoaneurysm could flow up into the distal vasculature. What we also saw was that there was quite a marked discrepancy in the distal landing zone compared to the proximal landing zone. And so, in all likelihood, a single flow diverter was unlikely to be suitable for this treatment. plus additionally, I was concerned that a single flow diverter acutely may not suffice in causing a rapid occlusion of the pseudoaneurysm, particularly because the patient was going to require full heparinization, so anticoagulation on top of antiplatelet medication because of the metallic heart valves. So because of these two reasons, I decided to place two telescoped Silkvista baby flow diverters, which I managed to navigate up through a Headway 17 over a Synchro 2 micro wire. And here we can see the telescoped flow diverters, very nicely seen with the overlapping coverage at the site of the dissection flap and the site of the pseudoaneurysm. On this on-table vaso-CT, you can still see filling of the pseudoaneurysm at this point. This is the final angiography. Again, hand injections done very carefully. And still some filling of the pseudoaneurysm, but much slower. And also some stagnation seen at the end of the run. You can see some nice stagnation there. So the procedure was fine. In terms of antiplatelet medication, what we normally do is, rather than preloading, we make sure that we have an NG tube in place in order to give crushed prasugrel, and this helps more rapid absorption of the drug. We give a bolus dose, weight adapted, of integralin shortly before deploying the stents, and also an IV bolus dose of aspirin, 500 milligrams. And we choose to give prasugrel in all of our cases because for acute stenting, because of the issues with clopidogrel not working. And the demographic of this patient would suggest that there was a high likelihood that they would actually have the gene abnormalities or to make clopidogrel insufficient. She was, after she'd been stopped for her warfarin when she was admitted, and the warfarin was stopped with Octoplex. After the procedure, she was started on a heparin infusion. There was close liaison between between the neurosurgeons, the intensive care doctors, and the cardiac surgeons who had previously been dealing with her. And so we opted for a heparin infusion and to continue the aspirin and the prasugrel. We don't continue with a 24-hour integralin infusion, actually, and in our experience, we've not had any complications from withholding the infusion of GP2B3A antagonists. As with all of these cases, we do an early IV DSA to monitor the pseudoaneurysm. And in this case, we performed it at 72 hours, and there was no evidence of filling of the pseudoaneurysm at that time point. She had a stormy post-operative period. However, she was discharged approximately 6 weeks after the ictus. And at most recent clinical status and clinical examination, she'd returned to work, and MRS was sort of 0 or 1. She's made a very, very good recovery, actually. Most recent MRI follow-up showed no evidence of medullary or pontine infarction on the MRI scans, and you can still see flow through the flow diverter stents tracking distally. For obvious reasons, we haven't performed any more catheter angiograms, but we did perform some delayed IV DSAs. So that's the end of the case. I'd like to invite everybody to Brain Conference as well, which will be happening in a couple of weeks. Mario will be speaking, as long as lots of other great speakers, many of whom are actually presenting at Nightmares. Thank you very much.
Yes, highly recommended the Brain Conference, by the way. So I hope you guys go there because it's going to be awesome.
Thanks, Mario. Thanks. It's another great collaboration between us, I think. So I suppose, I guess the questions will come from my colleague Levan, who knows well about this case. Manny, is there anything else you would have done differently, perhaps?
No, not really. I mean, I can imagine how difficult it is to catheterize these. I sometimes don't have the patience for all this. Sometimes I usually call my colleagues to help me out, because I get very frustrated with these kind of anatomy catheterization. So I can imagine how difficult it is.
Yeah, I think you and Levan share perhaps similar tendencies with a lack of patience. Then maybe.
Just a quick question I want to ask you is that I think my connection got a bit lost in between. The other vertebral was good caliber.
So it was actually on the CTA. It looked like it was of good caliber, but it looked like it was stenosed at the origin. And the problem is she had a type A dissection. So there was no real way for me to go across from the groin to check it. And I didn't really want to do too much catheter angiography for fear of either making the aortic dissection worse and potentially killing her on the table, or causing a dissection elsewhere. So for example, if I had checked and said, okay, well, let's say I'll do a deconstructive technique. If I've also dissected that and not realized, well, then I've really deconstructed her posterior circulation. So it was a tricky, I think it was a tricky case because of all of those, the inability to get as much information as possible, which is often what you would like before doing one of these cases, right? So.
To make a comment, not just your patience, the skill, and also the improvement in technology is testament to our ability to treat. In my case and your case, 17 catheters with a flow diverter in, old school, pipeline ones, no chance.
I completely agree. I think it's the technology is moving at such a rapid pace, and when I looked at that case, I really did. I was so thankful that Silk had made the Silk Vista baby and that we had it on the shelf, because I was really not looking forward to trying to track at 27 or something else. And I think if that had been the case, if we didn't have the Silk Vista babies, probably my only other reasonable alternative would have been to overlap multiple baby Leos, or which is what we had at the time, because we didn't even have the Evo then. And so I would have had to overlap, probably I would have said at least three or four baby Leos to achieve a sort of similar result.
There is one question from the audience, Paul.
Yeah.
What's the rationale for using aspirin if you are going to give an integralin anyway? So, because you mentioned that you may administer it 500 milligrams IV. Yeah. So if you are using, what about you only using, for example, Agrastat, and then next day switching to double?
Yeah, so this is a good question. I think there's a lot of, the concept behind antiplatelet agents and when should you use which ones, that's a 24-hour discussion right there, right? So the reason that I give the integralin is the integralin half-life is actually not very long, so that will have worn off within probably, I think, 4 or 5 hours. You will have lost it. So you either keep them on the infusion, and then you sort of give the aspirin or the prasugrel as well, and hope that that's taken over. Personally, I think that probably maybe carries a slightly higher risk of a repeat bleed than giving it a short bolus to cover the prasugrel coming in, and the aspirin gets to work within sort of 30 seconds essentially. So that's why I do that. I try to deliver the drugs in such a way that I'm playing with the half-lives of the drugs to optimize coverage, but to minimize the risk. What my biggest concern is to give everything at the same time, and then you've got everything, P2Y12 on board, thromboxane inhibition, GPTV3A antagonists. This patient's on heparin, she's anticoagulated, antiplatelets, that's it. If she repeat bleeds, you're toast. So that's why I play with the half-lives of the drugs a little bit. And so far, touch wood, it's worked, and I haven't had any in-stent thrombosis or repeat bleeds actually in acute cases.
Fantastic. There is another question. If you got, well, maybe Manny or Liban want to ask something else. If not, there is a question for the audience. What about just placing a lateral cut stent or one or two instead of the flow diverter? So what's your selection? Why the flow diverter in this case?
So again, the problem that you have here, well, it's not a problem really. The way that I look at this is you're essentially dealing with potentially two problems. One, you've got the flap, and then the flap's open, and that's why you're getting the flow into the pseudoaneurysm. If you place the laser cut stent, then you hope that you do close that. And actually, when I was in Sweden, that's what we used to do. What we saw, though, unfortunately, in many cases, was on the early IV DSA, the pseudoaneurysm hadn't gone. And in some cases, in quite a few cases, actually, even after you'd put three or four sometimes even of these laser cut stents, the pseudoaneurysm was still present and it was occasionally growing. There was one case where we ended up having to put 7, but that occurred in repeat procedures. So in this scenario, my absolute worst case option would have been, I do the procedure, I put a couple of stents, but the thing hasn't gone and she's got all of the risk, but none of the benefit. So in that case, and I really didn't want to come back and do a repeat procedure in this lady because of the obvious risks from the ejection fraction, from the insufficient treatment of the aneurysm, plus the risk of I dissect something on the way up in a second, third procedure. So for me, it was a case of, I have to do something here that is going to virtually definitely get rid of this aneurysm. I don't want to come back. And it was deconstructive, which I couldn't have been 100% sure I wouldn't have resulted in a posterior fossa infarction or flow diverters.
Okay, Paul, I think you may close the session.
Lovely. All right. Thanks, Mario. Thanks, everyone, for watching. We hope that the cases from England have sparked some interesting thinking. Look forward to seeing everyone, hopefully when COVID is out of the way. And please feel free to join us at Brain Conference. Thanks very much.
Okay, so we finished Europe, and now let's jump to Argentina. Will be moderated by Walter Casagrande. Let's go.
Hello, how are you? Good morning for everything. I am from Argentina, and I'm going to share with you 3 interesting cases with my friend, Dr. Alex Spiota from Medical University of South Carolina. We work together through the interrelationship by the web with the pandemic state now. And another friend is Roberto Crosa from Montevideo, Uruguay. And we work together with Cynthia Purves in the other side of the Rio de la Plata here in Buenos Aires. I'm going to share with you, and I hope you enjoy this case. First, Alex Howard, go ahead, please.
Thanks to the organizing committee for making me a part of this year's Nightmare Summit. I'm very excited and honored to be part of this. I'll be presenting the case of a nightmare recurrence of a giant basilar apex aneurysm. Here is the initial angiogram. Prior to treatment, you can see a fairly well-sized basilar apex aneurysm with a broad base. incorporation in particular of the right P1 of the PCA. At initial treatment back in 2015, we did a stent-assisted coiling with the barrel stent. And went out the right PCA due to its being more incorporated than the left. And at the time of treatment, we had a fairly good, what I thought was a fairly good treatment. You can see in the AP view still some body of the aneurysm filling. On the lateral, you can see a trickle flow on the posterior wall, which is really the sign of bad things to come. But at the time, I coiled as best as I could, and I really felt like we'd have a pretty good result. Here is the angiogram at 1 year, back in 2016. You can see the AP view looks well occluded, and of course, in the lateral view, you can still see that filling on the posterior border, although not really any worse than it had been at the prior year during treatment. So I felt like this was quite a reassuring finding on the follow-up angiogram. We spaced up the follow-ups to 2 years later. Again, looking at that fairly good treatment at the 1 year follow-up. And at 2 year look, you can see a terrible and nightmarish recurrence. So at the 2 year follow-up angiogram, now 3 years from treatment, you can see the measurements there, 15 millimeters by 20 millimeters of the contrast filling. The actual aneurysm, of course, being much larger, having partial thrombosis within the aneurysm dome, 3 to 4 times the size of the original aneurysm. You're looking more closely, that classic tipping of the hat appearance with the aneurysm now protruding more anteriorly and tipping over, and then the aneurysm having grown posteriorly and superiorly, again with a large area of active thrombus within the aneurysm dome itself. So the question is how to deal with this recurrence. At the same time, obtain a CAT scan, you can see compared to the MRI presentation, you can see the large aneurysm at the time before treatment in the third ventricle and the size of the ventricles at baseline. Now you can see the much larger aneurysm, again, partially thrombosed, having a dramatic mass effect upwards of the third ventricle and through the foramen Monro. You can see the much larger in caliber of the ventricular size with transependymal edema. So there was evidence of obstructive hydrocephalus at the time of the follow-up angiogram as well. Although clinically, the patient was doing fairly well, just had a slight deterioration over time. So one of the first things I did before treating the aneurysm was deal with the obstructive hydrocephalus. So I performed a ventricular peritoneal shunt, and I went from a parietal approach rather than a frontal approach, trying to avoid inadvertently contacting the large aneurysm with the ventricular catheter. I felt it was important to do the ventricular peritoneal shunting for CSF diversion to lower the cranial pressure before addressing the aneurysm recurrence, which would likely entail aspirin Plavix, and the antiplatelet regimen would make a shunt more dangerous afterwards. So shunting was done immediately to remove that from the equation, and we waited a short amount of time until we addressed the recurrence. The question really became, what would be the best treatment strategy for this previously stented, stent-coiled aneurysm, such a large and nightmarish recurrence? And I asked many colleagues and friends around the country, in fact, around the world, received many, many different thoughts and opinions, and ultimately I chose a strategy which would turn this aneurysm from a bifurcation aneurysm to a sidewall aneurysm, trying to utilize this strategy to make it to make the chance of recurrence as low as possible. And that began with studying the potential collateral routes to the posterior cerebral to the posterior cerebral arteries. So looking back at the angiogram, really studying things very carefully on the right side from the right side injections. That way you can see the intracranial athero throughout the intracranial vessels also. The right posterior communicating was essentially non-existent. The left posterior communicating, fortunately, was small, but you saw flash filling of the posterior cerebral artery in a heart injection. So flash filling and then, of course, clearing from the posterior circulation flow. But there was a communication and a route for blood flow to get from the carotid on the left to the left posterior cerebral artery. And that was really the key to devising this strategy to turn this from a bifurcation to a sidewall aneurysm. Again, this was the strategy. We know bifurcation aneurysm is more complex, higher risk to treat, higher chance of recurrence, higher chance of needing adjunctive devices like stents. And a sidewall aneurysm have a much different, much more benign natural history. So the attempt was to turn this very difficult aneurysm to a more simple sidewall aneurysm. So this is the approach. At the time, I chose a transfemoral approach. Now, in my current practice, I would use a transradial approach. We use a larger guide catheter, an 088 Neuron Max, which will be able to accommodate simultaneously in parallel two larger catheters, an 027 Phenom catheter for the delivery and deployment of a pipeline flow diverter, and an 025 PX Slim catheter for the introduction of large, high-volume PC400 coils. So first, I accessed the aneurysm and deployed a large number of high-volume and very long coils. And I was not attempting to coil it to obliteration, especially with the active thrombus within that aneurysm. I was just trying to introduce a fair number of coils to induce the thrombosis and then to place a flow diverter. So I first coiled, and then with the catheter remaining within the aneurysm, and with some difficulty, I'll acknowledge it was somewhat challenging to access the right PCA through the previously placed barrel stent. I was eventually able to do so. And again, we're looking here on the lateral view from a vertebral artery injection from the guide, a strong injection. You can see the posterior communicating on the left side, cross-filling and flash filling of the supraclinoid carotid. And that's the collateral route to the left PCA that I so desperately needed for the strategy to work. And I was, again, with some difficulty, able to cross the barrel stent and place a short 3 millimeter by 12 millimeter flow diverting stent from the right P1 to the top of the basilar apex, crossing the neck on the right side. Now the left side remained unprotected and not yet fully coiled, but that's where I needed the collateral for the PCOM on that side. So as I proceeded with coiling, having jailed my PX Slim catheter behind the pipeline and thus requiring the larger guide catheter, I continued to coil, and I allowed the coiling to proceed with protection of the pipeline. The coiling proceeded until it came down to the neck and actually coiled behind the pipeline itself and coiled off the P1 origin on the left side, knowing that the PCOM would be sufficient to provide the collateral flow to the distal territory of that posterior cerebral artery. You can see here in these posterior circulation runs through the PCOM flash filling of the carotid on the left side. You can see the coils extending from the in the aneurysm down to the neck behind the pipeline and now occluding that P1 origin. Until finally, with smaller coils, and while withdrawing my microcatheter, which jailed behind it, I actually coiled, and this is one of the last runs before I coil occluded that P1 origin on the left entirely. You can see flow still going across the coils, flash filling of the PCOM here. You can see the left carotid terminus and supraclinoid filling on the left. No more filling of the aneurysm. And at that point, I proceeded to coil more, and then here was the ultimate result. So again, the strategy of turning this aneurysm and the nightmare recurrence that had transpired from a bifurcation to a sidewall. So here again, we have a pipeline flow diverter within the barrel stent from the right P1 to the basal apex, coiled the aneurysm, again, not completely, but to induce the thrombosis, but most importantly, coiled to the neck and the left P1 origin, so that essentially now we have a sidewall aneurysm, and the posterior circulation ends entirely in the right PCA, and the left PCA has been excluded from the circulation entirely. And here, now we're shooting the left carotid after concluding the aneurysm treatment. And as expected, we're seeing through the small PCOM, we're seeing filled contrast filling of the left PCA. And here the difference compared to the prior treatment, of course, is not washing out from the posterior circulation, because this is now the exclusive supply to the left PCAs through the carotid. Again, having accomplished that, we've turned this very difficult aneurysm from a complex bifurcation to a more straightforward and more simple sidewall aneurysm. So again, it began with this nightmare recurrence of this bifurcation aneurysm previously treated with a stent coiling, pipeline flow diverter within it, coiling down the neck behind the pipeline, and allowing the PCA to be filled on the left side to the PCOM, and thus converting this from a bifurcation to a occluded sidewall aneurysm. Thanks so much. Hope you enjoyed the case.
Alex, the water hammer was or did a big problem in endovascular treatment of the aneurysm for the beginning now. For that, you consider to use for the beginning one small conventional stent like Elvis Jr. or Baby Leo in this case?
Absolutely. Thanks, Walter. Great question. I think these large basilar apex aneurysms, like is at the water hammer and the direct flow inward. I think you're right. The recurrence, which is the nightmare, could we have done better at the first stage? And this case was done many years ago. But I think you're right. I wanted to stay away from a Y stent reconstruction. But I think with the single stent, I think you make a great point in Elvis, maybe having some more flow diversion. Because that geometry with the two PCAs coming straight back, that inflow, the water hammers directly up. And when I first coiled in the stent coiling, the first stage, although it looked pretty good, on the lateral there's a little bit posterior flow. And it's amazing. 1 year it looked pretty good. 3 years it came back terribly. But yeah, I'd be curious for the other discussants what they would have done at the first treatment to try to prevent the big recurrence.
Well, now we have another device to prevent to have one better occlusion of the aneurysm, like Piconus. You have so much experience with the Pulse Rider, but what do you think about the use stent versus this kind of device? Because when you use the stent, you change the arterial anatomy and you change the shear stress in the neck, no, of the aneurysm.
Exactly. I think that's a great question. You know, other devices like the Pulse Rider or Piconus, I think in some of these large, giant basilar apex aneurysms, I think they're just very different from a regular aneurysm. And with that inflow being directly to the aneurysm, I'm not sure that anything would have done better than what I did with the stent coiling. And I think ultimately it took a really drastic strategy, like I showed, going from a bifurcation aneurysm to the sidewall. And it's only possible because fortunately I had the little PCOM on the left side. Now, I'll say when I did the stent coiling, I did go out the right PCA for the two reasons. One is the neck incorporated the right P1 more than the left. So I felt it was important to stent out the right side to protect the basal apex. But also I looked at those PCOMs and I wanted to have access from the left PCA. I had not yet thought about this strategy. I hadn't done that before. It was a new strategy for me. But I had an instinct to leave that left PCA without any device because that's where I had the PCOM supply. So I think in my mind I was expecting a recurrence, even with the close follow-up that we did. But I think some of these giant aneurysms are just behave differently than other aneurysms. They behaved in a more sinister way.
Another question, did you consider occlude P1 in the left side in this case?
Yes, at the first treatment or in the follow-up?
Okay. Robert?
Yes, so at the initial treatment, I did not think to do that initially, but certainly with the recurrence as it was and with the symptoms and the mass effect, and at that point, that was the nightmare, was the recurrence. It was a small nightmare, the initial treatment, then a big nightmare, the recurrence. And I think at that point, and I asked, dozens and dozens of friends and colleagues around the world, everybody had a different idea, which in these nightmare cases, it gives you the confidence that there really isn't a right or wrong answer. So I took, elements from different strategies, I combined them into one strategy. But I think the key is that these aneurysms behave differently. They behave more poorly. And a sidewall aneurysm is so much easier to deal with from a treatment and a durability standpoint. And at that point, I was willing to take the risk of occluding that left P1 origin and risking a perforator stroke. But I felt like with that large aneurysm, the perforators have probably been remodeled over 10, 20 years. So I felt it was fairly safe. But again, given the risk of the aneurysm continuing to grow, I definitely don't think, when I look at the recurrences, I'm always going up, like in a fight. If someone brings a knife, you bring a gun. So if you coil, it recurs, I don't coil again. Then if it coils and recurs, I do stent coiling. If I do stent coiling and recurs, as long as you know you did a good job in the first treatment, you have to be honest with yourself. If you didn't do a good job, then you should do a good job. But if you did a good job with the stent coil, then I do a flow diversion. If you do a flow diversion, do a good job with it, and then it recurs, then maybe a second flow diverter. So whenever I have a recurrence, if I feel like I've done a good treatment the first, I try to be more aggressive with the second. I try to not repeat the same strategy in the first treatment.
Another strategy is sometimes go through the PCOM and cross to the P1, to the right P1 to the left P1, and put one single stent from P1 to P1. But this sounds very light, but it's not so easy, no? What do you think about it?
Exactly. It's a fun little strategy, and we always love to do it. I know our fellows love when we do any transcircular Willis stenting. Either you go, the P1, PCOM to the P1 to P1. I think here, I don't know that would have changed the inflow to the aneurysm to the degree that I needed it to. I think it's good in cases where there's a big circumferential involvement of, say, the basilar apex, where the P1 origins are both entirely incorporated in the neck. And that can make it easier than sometimes Y stenting. If you can't see the PCA origins, they're hard to get into. I think that's a good bailout option that is used rarely to try to get the both PCAs and the basal apex protected. So I think in general, it's a great point you raise, and it's a very good strategy to always have in the back of your mind for hard basal apexes. In this case, I don't think it would have helped, change the inflow to the aneurysm, the first treatment, and probably wouldn't have accomplished everything that I needed to with the second treatment. But it's tricky. The PCOM has to be big enough to get not just your wire, your microcatheter. You have to feel confident it's big enough to take the device within the catheter that will stiffen the entire system. But you're right. It's another good strategy to always keep in mind.
Okay. Mario?
Fantastic case, Alex. Awesome. There's a lot of questions, but we don't have time for continued discussion. This is a 1 hour or 2 hours case, but we need to move. So Walter, if you want, we can continue.
Okay. We follow with the presentation of Roberto.
Hi, everyone. Thank you for the invitation. It is a great honor to be a part of this NIMR Summit. My name is Roberto Closa. I'm a chief of endovascular neurosurgery from Uruguay. And the title of my presentation represents a case of ischemic stroke we treated recently with little success, unfortunately. This 80-year-old patient had been symptomatic for 90 minutes on arrival to ER. She had a NAH 13 with aphasia, right hemiplegia, and eyes deviation. According to the CT data, she had an occlusion of left M2 with an aspect score of 7. She was not a candidate for RTPA according to the neurologist. Here you can see incipient signs of acute ischemia and a sequel of occipital infarction. And no, until this moment, the DSI confirmed the M2 occlusion. You can see in the left print, you can see the M2 occlusion of the frontoparietal branch and the affect area in the frontoparietal lobe in the right. Entering the left internal carotid artery was difficult because of an aortic aneurysm. We also found some complicated vascular anatomy. Finally, we made it with the neuron 088, but only until the first portion of the carotid artery, like you can, as you can see in the right side. In this situation, we decided to use stent retriever, Solitaire FR 420, but we performed a mechanical thrombectomy, and the results were not what we were expected. As you can see, we have now thrombus in the distal carotid artery, occluded M1, and even we have thrombus in A1. And the nightmare start here for us. We decided then to try again with another device, in this case ACE 068 system. And finally, we could aspirate a large clot. And the final results, you can see here the catheter, the 068, and the neuron 088. This is the final result in the DSA. Partially satisfactory because although we had achieved the reperfusion we wanted, we also found a distal occlusion of A2 in the left side. On considering the duration of the procedure, on the cardiovascular instability of the patient, we decided to put an end of our work here. Here you can see in the front view the result in the DSI and the perfusion. The control CT 24 hours later show an ischemic frontoparieto-temporal area on the left side. The last images was not loaded, but we have them now, and we have a configuration of an infarct in the parieto-temporal lobes. During the ICU stay, the patient developed pneumonia, which further aggravated her cardiovascular condition. The patient is now under neurological supervision by our team and under treatment by neurophysiotherapy department. The patient is with the fascia and moderate hemiparesia predominating in the right arm. Thanks for your attention. I'm open for questions.
Just in case, Roberto, maybe the first question, what one I do in this case is you use one catheter balloon, but when you treat elderly patients, the catheter balloon in one difficult arc is more difficult too. Even through the transradial approach is another option, but in this case, sometimes the aortic arc is difficult too. One question maybe is what you prefer to use in distal occlusion in M2, like this case, do you prefer to use one stent retriever or aspiration?
In my case, thanks for the question. In my case, 99% of cases I treated with LVO, I use aspiration. But in this case, something I didn't say, it was I started with the aspiration system. But when I put the 068, I lost the neuron immediately. This patient had a big aortic aneurysm, and it was really hard to achieve the occlusion with the 068. So in this case, particularly in this case, especially in this case, I decided to use a stent retriever. I thought maybe it's better for this case, and I use in this case this Solitaire, but the result was not what was expecting.
I want to discuss with you, with Alex, with you, Roberto, and Cynthia. One problem in the thrombectomy, or during the thrombectomy, is the coagulophragmentation. What do you think about use heparin during this procedure? Did you use usually that you prefer to use RTPA? What do you think about Alex?
Great question, Walter. I think number one is that there's really no evidence one way or another, so there's no right or wrong answer. For patients with TPA, we definitely stay away from heparin. That's probably our only hard and fast rule. And then for the other patients, it's really a judgment call. Depends on the age, the size of the core infarct. Again, we don't have a set protocol, but it's a little bit on a case-by-case basis. But anytime that I think it's going to be a prolonged case, if it's going to be an intracranial athero, for example, I'm more likely to give heparin. I prefer to just, get in and get out without doing heparin. But if it's going to be a prolonged case, a difficult arch case, or if I start and the arch is taking a long time to navigate, then I'll give a low dose of heparin, maybe like a third of the dose that I would give, an elective patient. But curious to hear from the rest.
I completely agree.
Okay. Another question: How important you consider to exit the small thrombus in pericallosal artery? Because many times we have a collateral from the posterior pericallosal, for example. Did you consider the risk of going to catch this small thrombus?
It's for me?
Yes, for both.
Yeah, in this particular case, we decided to go out because I don't know. I didn't want to provoke another nightmare, and for me, it's a minimal risk to left the clot in the A2, and we have not another catheter to use. It's difficult to when you decided to use devices here in Uruguay, you have in your head all the time that everything that you are using, the patient have to pay immediately. So we are, I don't know, it's not so free to use devices. So when you decided to use aspiration, you have to use aspiration, and it's difficult to think and change your strategy during the procedure, and this is bad for our specialty, but it's like that. It's the way we work. But in this case, we decided to left the clot in the A2. Of course, we could go there with a stent reaver or with a 3 max or even with the bigger catheter to aspirate the thrombus. But we were leading the nightmare at that time. It was 1 month ago. It's not so old.
Okay.
There is one question for the audience, guys. Is in these particular cases, when you have a fragmentation and then you have a distal migration, do you consider to change the anesthesia and intubate the patient? In case that you start with sedation, do you intubate the patient or do you continue just with the sedation? I think it's a controversial point. What do you think, guys?
In my case, when the patient when you couldn't control the patient, I prefer in those cases, in those complicated cases, I prefer to intubate the patient, especially if it's the left side who is compromised in stroke. In another cases when the patient you can talk with the patient and the patient can be I don't know, can be
stable, right?
Stable, yeah. I don't use intubation. I don't know. I don't use general anesthesia. But this case by case by case, you have to decide it. I don't know if there exists a rule for that. I know there are a lot of discussion about that, but I don't think if you can create a rule for all patients.
What about you, Alex? Because we have different trials going on. We'll have the answers, hopefully. But what is it? How are you managing this?
I think I agree with Roberto. For us, the only cases where I go in and plan for anesthesia are the ones where intracranial atherosclerosis, where I'm planning a angioplasty and stenting. But whether it's a distal occlusion that we know about at the beginning, or like you mentioned with the question, it's a proximal occlusion that becomes a distal during the procedure. I still try to just get it with aspiration as a frontline modality. And I still try to, as long as the patient is not moving, sometimes they're moving, you have to deal with it. As long as they're not moving to the point where it's unsafe, I would not convert to the question, and I would not convert to general anesthesia just because of that A2, for example. And I think to Walter's question about chasing that A2, it's, I think it all depends. You have to know your team, yourself. You know, we do distal occlusions pretty commonly. I know, Roberto, you've been with me when we've done M3 and A2, A3s. So I probably would have attempted it in this case. It's also on a case-by-case basis. Sometimes if you go in and the M1 is recanalized within minutes, maybe an M3, you're more likely to go after the M3 compared to if a case becomes a nightmare, you're less likely to go for the M3 after you have a good result or an A3. So I think it's really up to the judgment of the person doing it. But I do go after distal occlusions without anesthesia, and I do that pretty routinely.
Exactly how much, but I'm just going to say right.
The discussion about to use anesthesia or general anesthesia in stroke is usually, but we learn with the aneurysm treatment at the beginning, we use in some place the treatment without anesthesia. But we learn that when we have general anesthesia, we have one complication, the morbid mortality was less for the patient. Maybe for the stroke is similar, no? What do you consider about it? Alex or Robert?
Alex.
Go ahead, Roberto, because I couldn't hear you so well. I had some people behind me. Go ahead, Roberto, and then I'll do the second.
Okay.
I didn't hear. Can you repeat the?
You prefer to use anesthesia? You consider that the anesthesia, general anesthesia, give us best results if you have.
Oh, got you. So yes, we feel strongly that we should not do anesthesia. And I think, like Mario said, there'll be trials, and we look forward to those results. But also, you have to look at your local hospital and what your team can do. So I know that we can be faster to recanalize the patient, and now especially with radial access, it's even easier. There's less discomfort. So if I can get the vessel open on our M1 times now are 8.5 minutes. So if we can get in and out quickly, it's not just faster for the patient, but also we don't have any blood pressure reduction, which I think is so critical for these patients, especially when they have an ischemic penumbra that's just hanging on by collaterals. So at the most critical time of the brain, even a transient hypotension can really progress an infarction. So you really have to understand your team. And I know with our team, with our setup, it's just easier. And yes, you'll have 1 out of 20 patients will start moving and maybe become problematic. But I think at the population level, I think we help more patients with our institution where we can go in directly and be faster.
I think also one point, guys, is if the patient received before IVTPA or not. If the patient received IVTPA, we intubate every single patient because we have a high rate of perforation. If not, you may continue as Alex mentioned. That's my opinion. I don't know what you think.
Okay.
Yeah, it's a great one. I think it's again, it's all about understanding what your team and in your hands, your own complications. For TPA, it doesn't affect what we do or distal either. If it's something, a primary distal occlusion like an M3 or an A3, we'll still try to go up and do it with awake, even with a TPA. But we're also very conscientious. And again, for having studied our data like you have with your data with TPA, and you can change your group practice, we know from our data that after 3 or 4 attempts, the rate of complications goes way up. So we're very mindful of the time. After 30 minutes, 3 attempts, we have to revisit because most of the time we're already done. So if you're continuing, you're asking for more nightmares. So we're very conscientious of the number of passes and the number of time that we're working on the recanalization.
Okay, thank you. Thank you, Robert. Thank you, Alex.
Thank you.
We go to the third cases. Cynthia, go ahead, please.
My name is Cynthia Purves. I work with Dr. Walter Casagrande. I'm a neurosurgeon and neuroradiologist from Buenos Aires, Argentina. We are going to present a case that we named Taking Advantage of Neurosurgical Resources for Carotid Cavernous Fistula. We present the case of a 68-year-old woman who suffered from bilateral deafness secondary to congenital rubiola. She wore cochlear implants. She had bilateral cataracts and decreased visual acuity secondary to retinal detachment 2 or 3 years before this consult. She went through a medical screening with no prothrombotic factors, no neoplastic or paraneoplastic disease. The first digital angiography done in 2017 showed an indirect fistula type D barrow cavernous carotidal fistula. In this picture, we see both internal and external carotid arteries, with arteries arising from the linguopapillary trunk and from the internal maxillary artery. In this picture, we cannot see it, but later we will put in evidence that there was occlusion of the left cavernous sinus with no opacification of the inferior petrosal sinus. When we move to the carotid external artery, we could see the fistulous point, the beginning of the inferior ophthalmic vein, and the overload of the vein. A more close picture showed a direct communication between these small arteries and the fistulous point with the arising of the inferior ophthalmic vein. In this run, we can see from the contralateral side that there is no circular sinus, no opacification of the left cavernous sinus or the inferior petrosal sinus. We see some venous pouches that are not directly communicated to any of the deep veins. With all of this information, we had to plan a direct approach, and we chose in first place the transanterior approach that looked a little bit more simple. The first step was to put a guide in the external left carotid artery. We chose an Apollo catheter and Onyx, and we decided to occlude the arterial feeders. We navigated quite distally. We could acquire a good position, and we injected Onyx without complications. It advanced without reflux. In the next slide, with an acquisition from the internal carotid artery, we see the penetration of the Onyx. We knew we hadn't quite advanced to the fistulous point, but we were quite satisfied with the results obtained. This is the control from the external carotid artery. We see that there is still some filling of the inferior ophthalmic vein, but we appreciated an important change. These photographs showed there was still some filling of the inferior ophthalmic vein, but we thought that as a first step, it was a good job. This is the control of the next day. The eye was worse, and we were still very worried about our possible solutions to this problem. We knew the next step would be a transvenous approach. In this approach, we see that superior ophthalmic vein was not possible, inferior petrosal sinus was not possible, and no circular sinus. We had experience in catheterizing the facial veins. We had experience in puncturing superior ophthalmic veins, but none of these approaches were possible in this case. In spite of this, we tried to do a transvenous approach. There was no direct access to the cavernous sinus. We can see a plexus of veins with no direct communication, and it was not possible to go from the contralateral side. So we had to abort this procedure and started thinking what to do. Fortunately, 2017 was the year of our first Argentine Neuroradiology Interventional Congress, and we had outstanding guests. We had Dr. Orlando Diaz, Dr. Chapot, Dr. Crosa, Dr. Spiota. On that opportunity, we had a case presented by Orlando Diaz, who presented a case of direct access to the cavernous sinus through the superior ophthalmic vein using DynaCT in the angio suite. We knew direct puncture was too risky for this particular patient, as we didn't have direct access to the superior ophthalmic brain, and the approach through inferior ophthalmic vein did not seem suitable, but it gave us an extraordinary idea. We knew direct puncture through the ophthalmic base was not convenient in this particular case, but what if we use the cranial base foramen? We were trained in foramen oval puncture for trigeminal neuralgia during our residency program, and this could be a good way of getting access to the cavernous sinus. We revised the literature and found this approach could be used for percutaneous biopsy. Foramen oval is communicated to the cavernous sinus, but we were afraid this would leave us in a too posterior position. So we plan to use foramen oval as a guide, considering all anatomical landmarks, but trying to make an anterior perforation in its anterior margin. And this is what we did. With a TIVAS needle, we made a direct hold in the cranial base. We advanced a headway duo through the TIVAS needles and put some coils in the cavernous sinus. First controlled, the injection of the veins showed us they were still permeable, and we decided that this would be our last possibility, so we completed with injection of glue. In our last control, internal carotid artery, it was completely occluded. This is a photograph of the patient in the immediate post-op. 2 days later, first ambulatory control. 1 year later, and this year picture showing complete resolution of the case. This is our group, and this is our team, and we have to remember none of the things can be solved alone. It's better to work in group. Thank you.
Okay, a big nightmare.
Yes, a big nightmare. That's correct. The patient was a nightmare, and the case was extremely complicated.
I prefer that if Roberto or Alec can do any question, because I participate in the decision of the treatment.
And Roberto participated in the transvenous approach.
Yes. I remember I was a part of this nightmare. I remember, but for me, it's a well-result patient, because you try everything for this patient. So congrats for the results. I don't know. It's a really difficult case. We talked a lot with Walter about that, and I don't know. I have not question for this.
Maybe one technical question is if you can use a double lumen balloon to inject onyx from more proximal position and try to arrive to the vein. Maybe it's one question, but in this moment,
I think that in those years we did not have enough experience with using balloon. I think that if we reconsider this case nowadays, we would consider using a balloon and inject an eclipse and inject onyx or another squid or field through the balloon, and I think we would have got better results. But it was the beginning, I think, of our experience using balloons.
Alec, did you use another approach for this case? What you think?
Well, first I want to say great case, because I really enjoy it because it shows two great things. And one of what Mario's doing, which is when you have nightmares, you call your friends and colleagues around the world and you rely on each other, like we've done with all our cases. And the audience may know I've done cases with Walter and Roberto. We've done strokes together in South America, and you guys have visited me in Charleston. So that's learning from each other like you guys did, and came up with a strategy together like I did with my basilar. So that's the beauty of our field. So a beautiful case to show that point. And the other one, the dural fistulas, and cavernous carotid fistula is also some of my favorite cases, because as you show, every case is unique and very different. So you first must map out and really study and interrogate the unique connections and anatomy of your particular case. And every one requires a different strategy. So there's some of the